Good afternoon, everyone. This is our annual HeLa conference. We've been doing it for now about 10 years or so between Westchester Medical Center and New York Medical College. And this is our mainly students, residents. You saw their posters outside. We selected 3, although really we could have had all of them come up and do oral presentations, but there's just not enough time. But our team at Westchester and at NYMC selected three abstracts to give oral presentations. And for this part of the program, I'm going to turn it over to Rahim Hirani. He's a MD, PhD student here at NYMC, and he'll be leading us through as these students present their wonderful research. Thank you.
Well, hello, everybody. Thanks for joining us today. My name is Rahim Hirani, and as Dr. Etienne mentioned, I'm in the MD, PhD program. It's a pleasure to be moderating this session. It's really exciting that, as Dr. Etienne said, this is the first time in HeLa conference that we put this research symposium, and we received 20 great submissions, which was very exciting. A lot of different topics, a lot of different fields, as you might have seen, from AI to neurology to psychiatry to other fields. So it's very exciting what's happening at NYMC and WMC. From our internal and external collaborators, we selected 3 posters that you might have seen outside, and they will be going in depth about their research. So the first presenter that we have the topic is social, economic, and health disparities associated with drug, alcohol, and firearm mortality in the United States from 2014 to 2022. And I would like to welcome Mr. Roshan Dan.
Hello, everyone. My name is Roshan Dan. I'm a student from Horace Greeley High School, and today I'll be presenting this project, which is the social, economic, and health disparities associated with drug, alcohol, and firearm mortality in the United States from 2014 to 2022. So to begin, I conducted a project in the past which looked at the impact of the COVID-19 pandemic on substance abuse and firearm mortality in the United States. And what we found is that from 2020 to 2021, there was a significant and progressive increase in mortality from these 2 causes. And since then, the CDC Wonder database has released the 2022 data set, and I sought to see how these trends have changed into 2022. So specifically for substance abuse, I looked at alcohol and drug-related trends. And then for firearm mortality, I looked at homicides and suicides. And what we can see is that specifically from 2021 to 2022, these death rates have started to decrease or stagnate since 2021. And what this shows is that the long-term effects of the COVID-19 pandemic, mainly related to the mental health effects, as well as the pandemic-related stressors on communities, have started to decrease. So besides looking at the overall nationwide trends, I also looked at the different demographic disparities associated with all these different causes of death. And we find specifically is that for alcohol-induced deaths from 2021 to 2022, they have decreased across all different demographic categories. In particular, we saw the greatest decrease in the American Indian and Native non-Hispanic group. Also, we saw in firearm suicide deaths have basically become stagnant. So they reached its peak in 2021 and have become stagnant and not really decreased into 2022, which shows that firearm suicides remain a great issue that needs to be addressed in this country. Besides looking at these demographic trends, we also looked at the geographic distributions for these deaths. So at the top left, you can see the county level distribution of drug-induced deaths, then alcohol-induced deaths by county, and firearm injury deaths by county. And we sought to see how these different geographic distributions align with 2 different indexes created by researchers. First, the Community Resilience Index, and second, the Social Vulnerability Index. The Community Resilience Estimate. These 2 indexes were created by researchers in order to identify which communities in the United States are most vulnerable. And they take into account a variety of different social and economic factors, such as language barriers, access to internet, and income to poverty ratio. We also looked at the social determinants of health database to identify specific and individual risk factors, such as distance to the nearest trauma center or urgent care center, and the number of mental health care providers in each county. And what we did here is we ran correlations between all these different maps and all these different individual risk factors to see if these maps designed by these researchers can help us predict which counties have the highest rates of drug, alcohol, and firearm deaths. And the results of our study are shown here. So first of all, most importantly, we see the community resilience estimate from 2021 was significantly positively correlated with firearm injury deaths, drug-induced deaths, as well as alcohol-based deaths. And this is the same for the social vulnerability index. In particular, you can see that the community resilience estimate designed in 2021 exhibits the highest correlations with all these different forms of death. We also looked at the specific risk factors related to access of healthcare, and we found that the number of mental health care providers in each county, as well as the distance to the nearest urgent care center, exhibited the most significant correlations with these different types of death. And what this basically enables us to do is show how these different social and economic factors have a complex interplay with firearm, drug, and alcohol-based deaths. And what we can do is we can use those maps, as I showed previously, to now predict and show exactly which counties in the United States are going to be most at risk to different drug, alcohol, and firearm-related deaths. And so we can create different targeted initiatives and improve things such as urgent care and mental health care providers in these counties specifically. So thank you for listening.
All right, we have time for a couple of questions if anybody have questions for Roshan. No questions? Okay, I have a question. Are you sure you're in high school? Because like I didn't know half of these terms when I was in high school. So, I mean, very impressive.
Thank you.
Congratulations on your fine achievement. So for this achievement, I would like to request Dr. Etienne to come forward and hand you your certificate of achievement.
Thank you very much. Thank you so much. Thank you.
So moving forward to our second presentation for this afternoon, we have another topic, assessing diversity in sports medicine and brain injury medicine fellowships and ACGME and US Census comparative analysis. And this presentation is by Mr. Ryan Mohepur.
Good afternoon, everybody. Thank you for having me here today. So my group and my colleagues and I looked at assessing diversity in sports medicine and brain injury medicine fellowships using the ACGME database as well as the US Census. So a little bit about the background and purpose of this study. The reason why we wanted to investigate this was to determine the racial and ethnic composition of these fellowships within the ACGME and compare it to the US Census. So essentially, the reason why diversity in medical fellowships is important is it helps enhance patient care through culturally competent physicians, addressing health disparities that affect minority communities, as well as fostering a diverse learning environment. So the data sources that we used was the ACGME fellowship data. For those who are unfamiliar with the ACGME, this is the Accreditation Council for Graduate Medical Education. So we assessed the data from the years 2021 and 2022 and compared it to the US Census within the year 2020. And some of the fellowships that we analyzed were sports medicine, which was offered by 5 specialty programs, emergency medicine, orthopedic surgery, pediatrics, family medicine, PM&R, as well as brain injury medicine, which was offered by PM&R and neurology. So the statistical analysis that we used was a fellowship to census disparity ratio, and we generated a heat map here, basically laying out the specialties that offer sports medicine as a fellowship and the race ethnicities that were reported for that following year. So as you can see on the left-hand side of this heat map, multiple race and ethnicity as well as Asian were reported higher in comparison to the other racial groups as they are above a value of 0. And then within this lower chart here, this is assessing the brain injury medicine fellowship within PM&R and neurology. So Asian was reported as the most represented within this fellowship. And these results were all found to be statistically significant. So some of the key findings and implications that were made, underrepresentation of Black African Americans and Hispanic Latinos within the orthopedic and family medicine, sports medicine fellowships. And they were also completely absent from the emergency medicine, sports medicine fellowship. And for the Native Hawaiian and American Indian groups, they were completely absent from all fellowship programs within these specialties. So some of the implications that could be made is that there are fewer minority physicians within these leadership roles, limited access to culturally competent care for these fellowships, as well as a potential impact on health disparities in sports-related and brain injury medicine. As a conclusion, we have found that there are significant racial and ethnic disparities that exist within these fellowships, and addressing these gaps is essential for equitable healthcare and workforce diversity. Some of the future directions that we would like to take is expanding this to a larger data subset, so incorporating more years within the ACGME database as well as the US Census, and trying to determine if there's any type of longitudinal pattern that we can find, as well as expanding this to other fellowship programs within the US, and using initiatives like the NFL's Diversity in Sports Medicine pipeline to create a simulation of how these fellowships would look like if we use their algorithm instead. And just another note on that NFL Diversity pipeline, the NFL Commissioner Roger Goodell came out and said that they are going to continue to sustain these DEI efforts within the NFL as they deem that it is something that they have proof of providing benefits for within the NFL itself. Thank you.
Thank you, Ryan. We have time for a couple of questions. If anybody have questions for Ryan on this project.
Hi, yes, so great presentation. So quick question. You mentioned that for the sports medicine, the specialties you looked at were the family medicine, emergency medicine. I'm curious to know, how were you able to pick those specific specialties as opposed to others, and what the process was like in grouping those together, in that, and also the brain injury medicine as well?
Great question. So the reason why we chose those specialties specifically is because they were the ones that offered sports medicine as a fellowship program within the ACGME database for that year. But eventually, as we expand the data subset, there may be more specialty programs that provide it as a fellowship opportunity, as well as brain injury medicine.
Right. Any other questions? We can take maybe one more, if there is any. All right. Yes, I think there is one more.
A great presentation, Ryan. Just given the recent administrative policies on DEI and whatnot, has your approach to solving this issue changed or evolved anytime, recently due to those policy changes? Do you expect that'll be a big, I expect it'll be a big hurdle for a lot of people here, but
I believe that, at least for the information that we can gather before the changes have been implemented, we might still be able to see some type of linear change. But with the DEI efforts that are being sustained by certain organizations, I'm hoping that the ACGME would also be a part of that.
all right, terrific. Thank you.
Thank you, Ryan. That was a very timely topic and great presentation. And I would like to, invite Dr. Etienne again and hand you your certificate of achievement. Congratulations. Right, moving forward, we have last oral presentation for this afternoon. The topic is artificial intelligence and transgender healthcare, a stress test. And I would like to invite Jessica Williamson for this presentation.
All right, hello, everyone. Good afternoon. My name is Jessica Williamson. I am a second-year medical student, and today I'm going to be presenting about my project, Artificial Intelligence and Transgender Healthcare, a Stress Test. This work is being done in collaboration with Mariam Ahmed, Rahim Hirani, and Dr. Mil Etienne. So starting with some background, as I'm sure all of you are aware, in recent years, the utilization of artificial intelligence or AI platforms has absolutely exploded in popularity. And the fact is that this increased use could lead to a paradigm shift in the way that patients receive information about their health, akin to the early days of the internet and WebMD. And we thought, is WebMD going to replace doctors? Things like that. We have concerns. So recently, large language models, which are the most popular form of AI use among the general public, have been shown to perpetuate racial bias and misinformation when evaluated using scenarios designed to evaluate the implicit bias of medical trainees like residents and fellows. Transgender patients are at a particularly high risk of receiving online misinformation, as they have been shown to be more reluctant than the general population to pursue healthcare in person due to the history of bias and discrimination and abuse in the healthcare setting for transgender patients. So for that reason, it's critical to establish whether or not AI is capable of providing accurate answers to questions about health from transgender people, as to date, this has not been demonstrated in the literature. We chose to go about this by completing a stress test. And so what we did was we chose 4 of the most popular large language models: ChatGPT, Claude, Google Gemini, and Meta AI. Each of these models was asked 17 different questions about transgender health that spread across a very broad array of disciplines, ranging from preventative healthcare to reproductive care, cardiovascular health, neurological health, and many, many more. These answers were then compared to the World Professional Association for Transgender Health, or WPATH, Standards of Care, version 8, which is our most recent version. And where the questions that we were asking did not have a corresponding guideline in the WPATH Standards of Care, we then used the most recent peer-reviewed papers that we could find that spoke directly to the topic at hand. So going into our results, it's important to note that the vast majority of the content that was generated by these large language models was accurate and did adhere to the standards of care and to the literature that existed. It's also important to know, however, that there were very different approaches taken by these different platforms, and that the discrepancies that did exist between the answers that were provided and the standard of care had the potential to be very impactful and potentially harmful to patients. So starting with ChatGPT, in spite of the fact that most of the answers were accurate, it did have a tendency to sort of go off on these tangents that were not directly related to the question at hand. This was particularly notable in an example where we asked it if transgender men who were seeking to carry a child should cease using their testosterone before attempting to become pregnant. And it started talking about how an alternative method of conception was using a sperm donation from another transgender man, which is not something that is currently biologically possible. Claude, for its part, would occasionally overcommit to these sort of binary yes/no answers, where the literature would sort of be a little bit more reserved because the data wasn't quite there yet. So there was that tendency to overcommit in Claude. Google Gemini would have the advantage of frequently citing peer-reviewed journal articles and very reputable websites like the UCSF Trans Health Database. But there was also the problem of it citing non-journal sources. So in one particularly influential instance, there was a New York Post opinion piece, an op-ed about transgender health that was full of very vitriolic and transphobic language, which is not something that we want patients to come across when they're searching for information about their health. And finally, Meta AI consistently provided the most brief answers, which has its pros and cons, but it also provided fake references to support its answers in almost a third of the questions that we posed to it. So what can we take away from all this? I think it's clear that there's a lot of potential for AI to be an invaluable tool for clinicians and patients alike. However, at this moment in time, the risk of misinformation and bias, as I've detailed, is a little bit too extensive to recommend a more broad adoption of AI at this moment in time in the healthcare sphere. Additionally, it's important that to prevent this sort of bias, transgender stakeholders are involved in the development of these models to prevent the deepening of these disparities. And then finally, it remains clear that competent and compassionate care from human clinicians is essential and critical for transgender patients who are seeking information about their health. Thank you all.
Thank you, Jessica. Great presentations. We have time for a couple of questions if anybody have any. Yeah.
Hi, Jessica. Wonderful presentation. Really, really interesting topic. I had two questions actually. My first question is with ChatGPT, did you find that there was any difference in the answers you got with the different iterations that exist of ChatGPT? So for example, 4 versus 3, things like that.
So it's a really great question. And that is a notable topic on its own, but it's something we try to avoid asking across versions in order to preserve the integrity of testing across different platforms. So we would ask the same question to each platform on the same day. And we use only the free versions as well of each of these platforms, it's important to note. And so that way we wanted to have a sort of a standard across comparison, but a potential future direction for this work is definitely to sort of compare across versions and chart how over time, how has the quality of the responses shifted. And your second question?
And my second question is, so prompting AI feels like more of like an art than a science. So did you find any difficulty in coming up with questions across the board that to use to prompt to get the answers that you required, like making sure maybe to ask to give you like peer reviewed articles supporting your question and things like that?
So what we tried to do was to ask the questions in a way that was deliberately at sort of layperson level. So we didn't want to think, so we thought of perhaps maybe the average person who's using AI to get information about their health may not know that they need to seek out these peer-reviewed sources. So we would use terminology that was used in the community. So for instance, like if we were asking about, instead of saying something like gender affirming surgery, we'd say something like bottom surgery or top surgery to make it more like what the patient would in particular ask. And so we did try it. We didn't really try to dig into saying, be sure to provide me with some sources. But again, that's another future direction.
I think we have.
Yes, thank you, Jessica. So I just wanted to follow up as on that aspect right there. So how did you said you developed 17 or you used 17 questions? How did you identify or develop those questions, and what did you do to avoid the bias that you bring to it as a professional and healthcare provider?
I'm sorry, the bias.
The bias that we bring to it as the researcher or the healthcare provider.
Right. So that was something that was very helpful. Dr. Etienne's role in the project was that he thought, what are the questions that I've come across when I've been providing care to patients? And so it was a lot of things that maybe were less clear. So things about pregnancy testing for transgender men prior to imaging with radiation and things like that. And so we just tried to focus on not really steering it in one particular direction, but just thinking what are going to be the high yield things that come up when a trans person is going to the doctor and the doctor doesn't know the answer to their question and they turn to AI. What are those questions going to be?
And as a quick follow-up, the responses that you got back from the platforms, did you do any qualitative analysis or quantitative analysis of its understandability or readability?
So that has not been done yet. So we started with just sort of doing a broad survey with as many sort of questions as we could. And then we're in the process for the actual manuscript of evaluating and developing a scoring method to see how closely do these actually adhere to the WPATH, how closely do these adhere to the papers, and things like that going forward.
Thank you.
I maybe we'll take the last question. I see there are many interests in this project. Jessica would be happy to connect with you just to keep it going. Sorry.
Hi, great presentation. I just had a quick question about your point number 3, that competent and compassionate clinicians remain the gold standard. So I was curious if you still feel like there is some use to the AI tools, and if so, how do you feel like they could be used?
So I think that because the vast majority of the answers that we got were accurate, that most of the time it's going to be better than nothing. I just don't think that it's a great first resource or a first choice for transgender people at this time. I think that if there's a bit more refinement done, that it could be more reliable. But I think part of the problem is that there is a dearth of information on trans health to begin with. And so the resources that it would be drawing from are very limited. And so the basic and clinical science needs to be done first, really, in order for this to have a more robust body of work to draw on and provide more sound advice.
All right. Thank you so much, Jessica. Very powerful presentation. very important topic, given that there is no data out there for this topic yet. For your achievement, congratulations, and I would like the team to invite the team to hand you over your certificate of achievement. So those were the oral presentations for this afternoon. The theme of this conference is advancing access and equity, moving from awareness to action. And as you saw that all of these presentations, including our poster presentations, did justice to this topic and theme. Let's hear a round of applause for all our oral presentations this afternoon. Now let's hear a round of applause for all our poster presentations. Last but not the least, I promise, give a round of applause to the team who put this together. All right, now that we all are warmed up, I would like to invite Dr. Militian and Mathilde Roman to officially kick off the conference and give welcome remarks. Thank you.
All right, good afternoon, everyone. You all are worn out already? Good afternoon, everyone. Yeah, we're excited. It's Black History Month, and this is our annual HeLa conference. We decided this year to do a little bit different by having the research presentations. Really, we wanted to recognize the great work in health equity, diversity, and inclusion research that many in our community are doing. I'm going to turn it over to Mathilde. Actually, we should introduce myself. I'm Dr. Etienne. I'm the Vice Chancellor for Diversity and Inclusion here at NYMC, also a graduate of NYMC.
My name is Mathilde Roman. I'm the Senior Vice President and Chief Equity, Inclusion, and Diversity Officer for WMCHealth.
Great.
Yeah. So it's an honor to welcome all of you to this important discussion on advancing access and equity. Today, we gather not just to acknowledge the disparities that exist in our society, but take meaningful steps toward bridging those gaps. The topic of today's conference has taken greater significance with the backlash of diversity, equity, and inclusion intensifying. DEI's mission has been misinterpreted, and deliberate actions have been taken to dismantle the progress that has been made. It is in this vein that we stand here today, steadfast in our commitment to move this work forward, to ensure every single person, regardless of their background or socioeconomic condition, has the opportunity to achieve their full health potential. In recent years, we have made significant strides in raising awareness about the inequalities that affect various communities, from education and healthcare to employment and housing. The conversations around equity has gained momentum. However, awareness alone is not enough. It is time to translate our understanding into concrete actions that drive real change. Our goal today is to move beyond discussions and focus on actionable strategies that can make a tangible difference. We will explore innovative solutions, share best practices, and collaborate on initiatives that promote inclusivity and fairness. By working together, we can create a society where everyone has the opportunity to thrive, regardless of their background or their circumstances. And as we embark on this journey, let us remember that advancing access and equity is not a one-time effort, but a continuous commitment. It requires dedication, perseverance, and a willingness to challenge the status quo. Together, we can build a more just and equitable world for all. Thank you for being here and for your commitment to this vital cause. And let us move forward with purpose and determination. Thank you.
Thank you. All right, now we're going to start with our program. And before we go into our speakers, I did want to have our Dean of the School of Medicine, Dr. Neil Schluger, come up and give some opening remarks to our audience.
Thanks very much. It's wonderful to be here, and I want to express my gratitude and appreciation to Dr. Etienne, to Matilda Roman for organizing this day, which I think has really become one of the very important days in our calendar here at the medical school. And the work that we saw earlier, the research presentations which have been added to the program, I think are a wonderful addition. But this entire event, as I said, I think is a very important one for our school. And I'm really grateful to all of you who have helped to organize it and participate in it. I was just thinking about my own relationship to the topic today and to the conference in general. And I was remembering back to a time very early in my career, in the early 1990s. My first job after I finished all my training was at NYU and Bellevue Hospital in Manhattan, and I ran the tuberculosis clinic at Bellevue Hospital at a time of an enormous TB epidemic in New York. It was quite interesting and challenging and fun. But one of the things that I will never forget, in a way, is related to the conference today and the things we're talking about. So at that time in the early 90s, one of the things we tried to do at the tuberculosis clinic was to link more directly with the people we were serving. Bellevue, as you know, serves an incredibly diverse population, drawn really from all over New York City, but particularly from Lower Manhattan. And we had some funding. We successfully applied for a grant from the Robert Wood Johnson Foundation, and we received funding to link our clinic with several social service programs in New York on the Lower East Side, places like Lower East Side Services Corporation, Bowery Residence Committee, Housing Works, that were providing social services to the same people that we were treating for tuberculosis. And the idea was to really take into account all of the challenges that those patients faced and to try to integrate the medical care with the social services they need, and provide really a more holistic approach to care. And so, as I said, we applied and received funding from Robert Wood Johnson Foundation to help us do that, along with 4 other locations in the United States. I remember one was in Florida serving migrant workers. I don't remember where the other ones were. And the Robert Wood Johnson Foundation gathered us, the 5 of us that had received funding from them. They would gather us from time to time and bring in speakers to talk about things that they thought were useful. And one of the first speakers they brought to us was the minister of an African-American church in East Baltimore, a church that was in the shadow of Johns Hopkins Hospital and School of Medicine. And I've never forgotten what he told us. He said his community, which, as I said, was in the shadow of one of the great medical institutions in the United States, his community always felt that that hospital was, in his words, more interested in studying them than taking care of them. And I've never forgotten that. And I've tried to remember that really every day since in my career as a physician. And when 15 or 16 or 17 years later, when the book, The Immortal Life of Henrietta Lacks, was published, I remember that very acutely, because when I read that book, I thought that was really the sin. More than immortalizing her cell line and not paying her family. I think that's a very complicated issue, but the real sin was that she lived in the shadow of a great medical institution and couldn't get the care that she deserved just because she was a human being. And that that's how we should see all of our patients, not as study subjects, not as faceless crowds of individuals, but as a human being, as a person who deserves care. So I've tried to hold that lesson from that minister every single day, actually, since then that I've been practicing medicine. And I think that's very much in the spirit of what we're here to talk about today. So again, my admiration, my gratitude, and appreciation to all of you for participating. And I look forward to a wonderful afternoon. Thanks very much.
Thank you. Thank you. Thank you, Dr. Schluger, for those remarks. And definitely, supporting our communities are very, very, very important. and help a great deal in kind of eliminating that mistrust that we often see. I'd like to invite, we're very fortunate today that our very own county executive made time out of his busy schedule to come bring us greetings from the county. So I'm going to ask Mr. Ken Jenkins, please come up to the podium. So much.
All right. So first, good afternoon, everyone. So for me, it's always great to be in front of anyone, but certainly during Black History Month and during this particular kind of a program where New York Medical College continues to show its leadership in making sure that we're embedding diversity, equity, and inclusion under the HeLa group. So again, for everyone that put the work together, Dr. Etienne, and certainly Matilda Roman. Let's give them a round of applause for their work. Matilda Roman. So, you know, in the county, we have a lot of things that we do in far as making sure that we continue to value, as the good doctor was just telling us, about diversity, equity, and inclusion. I usually tell a story that says a long time ago in a place called New York Telephone, where I had my first job when I was 19 years old, the managers made sure that they had to go through a program that was called efficacy, right? And it wasn't called DEI because we didn't know about DEI when I was working in a telephone company or IBM or Xerox or the many other corporations that did that. But they were doing this effort as a lead to make sure that the corporations were doing as best as they could to bring value to their shareholders. Their color was green. They weren't concerned about any of the challenges that have happened, and whether that's for LGBTQIA plus rights, whether it was about making sure that people of color and female and women were getting into those higher echelons of management that were getting overlooked because people didn't look like them. They didn't participate in the same activities, and they didn't go to the same golf club, and they may not have done anything the same. But the corporations were concerned because the company was not making as much money as it could because people were not having opportunity and access. And that's really the challenge as we continue this world right now where DEI is under attack because people misunderstand what it really means, which is about making sure there's equity and inclusion and that everyone has an opportunity to see that. So your county continues to be working with every entity, but specifically here at New York Medical College to make sure that everyone has this fantastic opportunity. And you have some great speakers that are going to be here this afternoon. Most of them I know from friends, whether it's Vinnie Bagwell and all the work that she does, and they're talking about genealogy and how all those things mix together and how you can do different work. And the county's work as far as inclusion, as far as our MWBE, SVDOB, DBE practices, where we make sure to expend at least $250 million over the last 4 years of work for the county. But that's only part of the conversation. And as was pointed out, it's a continuing effort. It's a continuing morphing, and it's a continuing way to move together. So on behalf of your county, I'm certainly privileged to be able to stand in front of you as the first Black county executive in New York, in our county's history from 1683, being the 10th county executive. Our county was incorporated in, thank you, Bob, Dr. Allen. But the real point is about making sure that we continue to lift up, understand how equity, diversity, equity, inclusion makes us a better society and makes us all be able to move forward in a way that people don't feel they're being studied, that they're being cared for. And that's all the role that you have here. So thank you for the opportunity to say a few words this afternoon. Happy Black History Month, and remembering Black history is American history. Thanks so much.
Thank you very much, Mr. Jenkins. And before we proceed to our program, we do have one more welcome from Dr. Halpern, who unfortunately could not be here. He had to travel, but he did record some remarks. We're going to play those for you now.
Hello, my name is Edward Halperin. I am the Chancellor and Chief Executive Officer of New York Medical College. I'm sorry I cannot join you in person for this meeting. My wife had surgery recently and is recovering. And I had a heart attack last year, and I still am going to appointments this week with my cardiologist. So I am, as they would say, otherwise engaged. But I did want to speak with you for a few minutes about the conference and ask you to think about a problem that medical historians think about, and that is the problem of drama versus melodrama and the concept of presentism. In melodrama, there are perfect heroes and perfect villains. They are archetypes, they are extremes. But in the drama of life, which is history, there are not, for the most part, perfect heroes and perfect villains. If you think about heroes, you could say that Governor and President Woodrow Wilson elevated the level of political discourse, talked about freedom of the seas and freedom of people and the right to self-determination, that he developed the 14 points for peace in Europe. He conceived of the League of Nations. He fostered the progressive era in American politics, things we take for granted now. But he was originally a Virginian and a racist, and his historical record, therefore, is mixed. He's not a perfect hero or a perfect villain. Clara Barton founded the American Red Cross. Her work led to important efforts in disaster response in the 19th and 20th and into the 21st century. But she couldn't separate her personal finances from those of the organization she founded, and eventually a divorce had to be brokered. She also wasn't a perfect hero. Achilles usually has his heel in history, which brings us to a topic that you're going to grapple with today, J. Marion Sims and the development of surgery for vesicovaginal fistulas. Was J. Marion Sims a perfect villain because he operated on enslaved Black women, Anarcha, Lucy, and Betsy? He didn't have informed consent. He didn't use anesthesia. Well, remember that in the American South, it's not at all clear if news of the discovery of anesthesia had reached J. Marion Sims by the time he had done the operations. Anesthesia was often lethal. Views of pain control were very different than they are now. So we really didn't understand principles of safety in anesthesia until the development of John Snow and the Broad Street pump era in the 1860s. Snow developed the principles of safe anesthesia in childbirth. Well, that's about a decade and a half after J. Marion Sims' work. You can't hold Sims at fault for not knowing something that hasn't been discovered or communicated yet. Was he a perfect villain for lack of informed consent? Our concepts of informed consent and medical experimentation from the Nuremberg trials and the Declaration of Helsinki would not enter our conversation for 100 to 120 years after the life of J. Marion Sims. The development of the Sims position, the Sims speculum, the use of suturing technique for vesicovaginal fistula were contributions, but as I've alluded to, it's human drama, it's not melodrama. The story is decidedly mixed, which leads us to the second concept, that is of presentism. Presentism is when you choose to judge the behavior of the people of the past by the standards of the present. You do so at great peril by holding people responsible for not living in 2025 when they lived 180 years earlier. We have to take care of, lest we fall upon our own sword in this regard. Every time we look back at the history of medicine and say, what were those people thinking? Look what they did. You have to remember that 50 years from now, people will look at our medical charts and say, what were they thinking? Look what they did. So I invite you today in your deliberations in the conference to remember the distinction between human drama of history and melodrama, to bear in mind presentism as a risk in engaging with historical figures. That does not mean one needs to abandon moral stance, a view of what's right and wrong. I'm only suggesting that it has to be tempered by the reality of human nature and human history. You have chosen difficult material to grapple with today. I wish you Godspeed in your conference and deliberations, and thank you for including me for a few minutes in the program. Have a good conference, everyone, and thanks for asking me to join you, albeit virtually by technology.
As you all know, Dr. Halpern, our chancellor, is also a historian and does teach the history of medicine course here at NYMC, and does spend a lot of time going over a lot of the topics we're going to be discussing today. So those were the introductions. We're going to, I know now you are probably all waiting for the discussion on Marion Sims and that history, but before we get to that, we do have one speaker we're going to have go up first. I'm going to introduce Dr. Daniel Correa. Dr. Daniel Jose Correa is an epileptologist, associate professor of neurology at the Albert Einstein College of Medicine, and he is also the associate dean for community engagement and outreach. Dr. Correa complements his clinical work with community outreach and public education, efforts to improve health outcomes and advocacy for people living with neurological disorders, and increase brain health awareness. In addition to working on the Brain and Life magazine editorial board, Dr. Correa is the editor and host of the AAN's Brain and Life podcast. And I'm also proud to say that Dr. Correa was one of my residents when I was on active duty at Walter Reed. So I'm extremely proud to see him doing this great work up here in New York. Dr. Correa.
Thanks again to Dr. Etienne, Dr. Roman, the organizers and the school for the invite. All right. Thank you very much. And I wanted to also start off by thanking, all those of you who are doing the work and the research right now, some of the poster presentations, the students on your pathway moving forward to look at what we can do now when we're asking that question of what were they thinking in the history and in the past, having some awareness and understanding of history and what was available to our scientists, physicians, and the community at present. But what's most important also is that we consider where we are currently at this present and start working on how to improve and move things forward. I thank Dr. Etienne and excited to see the continued work that he has been doing in supporting the pathway and the pipeline for so many people into medicine, and hopefully maybe more into neurologic specialties. And it's something that I continue in with. And what I'm going to be talking about today is within the area of neurology and the concept of brain health, work that we have been doing to increase awareness and fill some of the gaps that there are in health literacy related to those areas. A few things that we'll be highlighting, is talking about the things that contribute to low health literacy, sort of asking the question, are they unique to neurologic conditions, to certain communities, or are they in general seen consistently across neurologic disorders? We'll talk about some of the resources that have been developed. I stand here in front of you today as a product and through the support of many pathway programs. I include Dr. Etienne's mentorship as one of those. It starts with the support and advocacy of my own family and my mother, but many other formalized pathway programs in the Northern Virginia, DC area, and then also through a diversity leadership program within the American Academy of Neurology. That gave me opportunities to get involved in public health education around neurology. And so we'll be talking some about the brain and life resources that have been developed, and then formulating some practical steps we can each take. In terms of disclosures, as I mentioned, and as Dr. Etienne mentioned, I do work for the AAN as a portion of my time as an editor and the host of the Brain and Life podcast and on their editorial board. And then there's some financial stock things that won't have anything to do related to the conversations and topics that we hear today. Some of the work that I've been done is supported by research funded work within the state and nationally. But in general, none of those will be any concerns in terms of conflicts. So I wanted to come to where we are right now. Again, that idea of presence. So there's a lot of change in healthcare, and that can't even be boiled up into this, and that's all before November. And so there's a growing burden of neurologic disorders globally. So even the conditions that are present after someone has a neurologic illness that presents are already growing, let alone the question about addressing where we are with prevention of neurologic conditions. As already has been demonstrated, and I'm excited to see a greater awareness of it with some of the research work and the research posters that were done, we have to acknowledge there's a lot of persistence and in some areas worsening of health disparities and health inequities throughout our communities, whether we're looking at the United States or globally. There's increasing prevalence of chronic diseases. And as a component of that, thankfully, there's increasing awareness of social determinants of health, which in many ways in and of themselves are determinants of health inequities. And we need, and part of many of you here today, is we need a workforce and a community that's more equipped to address those challenges. So then we think of the idea of brain health. And one thing I realized earlier before here today is that we may not all necessarily be operating on the same understanding of what is the definition of brain health. And so more recently, and the AAN in the last several years, or the American Academy of Neurology, has had an initiative that they started called the Brain Health Initiative. So you'd think of neurologists all together, all they think about necessarily is brain health. But let's talk about what has been come together as the definition of brain health, and then we'll come back to that. So as the American Academy of Neurology has worked with the World Federation of Neurology to define brain health, they're calling it a continuous state of attaining and maintaining optimal neurologic function that best supports one's physical, mental, and social well-being through every stage of life. A few things to highlight in there. We're not necessarily talking about the neurologic condition or the presence of an acute injury and the neurologic condition that may come after. We're talking about optimizing someone's best physical, mental, and social state. And the key aspect there is we're also talking about social well-being. So there's a lot of this moving to, before you even see the neurologist, the concept of preventative brain health and prevention of neurologic conditions and chronic disorders. And then there is that recognition of every stage of life. There is a value of your quality of life that needs to be acknowledged in thinking forward. And so there's a lot that's changing overall within the brain health landscape moving forward. And a few points here that were included, but you had plenty of time with the slide. So some of what we'll be talking about today, and okay, the clicks aren't exactly working, but that's fine. Comes from some work that several colleagues that I completed and did AAN leadership programs with. We worked together on a textbook that is out now digitally and the print edition coming soon on achieving equity in neurologic practice. In that, we have chapters defining concepts that are important for neurologists to understand about health equity issues, along with chapters on every neurologic condition, including pediatric neurology as a general area, and women's health, on addressing where we are with health equity in those spaces and within the medical conditions varied. That includes a chapter that we talked about social determinants of health and dilemmas in healthcare. Health disparities in epilepsy. Behind the continuum photo is also a chapter that I helped edit on traumatic brain injury. This summer also will have a follow-up to some work that's been going on increasing awareness and brain health and actions that we're taking. But all of this is, are we championing or trying to target a specific population or a specific group that has limitations? And a key thing to come back to is anytime there is an initiative to address whether it's access to healthcare, access to medical education, is the overall concept of curb cutting. And so this is a concept out of disability access and awareness. So the curbs were on our sidewalks, and initially the idea of cutting the curbs was just for wheelchairs. But as people started to mobilize themselves around public spaces, it very quickly became clear that those who were in crutches, those who had walkers, mothers with strollers, everyone benefited from greater access, even in the social structural system of our community. And these are all things. So by identifying that there's a group that has a disparity in some aspect, access or health outcome, addressing a way to improve that, often we're going to see a carry-on effect to many of the other groups, whether they are a majority or served group or an underrepresented group, or a group that we're not actually even effectively measuring at this time. We've talked right now, more recently, we heard speak about the transgender care and the LGBTQI community. There are so many groups that have ethnicities that are underrepresented throughout our society, but we don't measure them in the current census system. And so if we are only targeting one group or one area, and we think and limit our idea that it's addressing that single group, we're going to miss out on the fact that once we get around to effectively tracking and monitoring another, that there are issues that need to be addressed for those. Okay, so animations are not working here. So sorry, this one's a little bit of a messy one. So a framework that has been developed by the NIH, and hopefully will have continued attention moving forward in the NINDS. So this is Neurologic Disorders and Stroke, a section within NIH. They developed a breakdown of all the areas where social determinants of health are present, but really clarifying it's not about positive or negative. These are determinants of health inequities throughout the system, and how they branch beyond just an individual. Our concept of medicine often is the individual and the biologic basis, but it goes all the way back to cultural, socioeconomic aspects. And so having an understanding and awareness, and a part where we want to get into here is, is specifically thinking about the educational level and health literacy of an individual. And so within brain health literacy in and of itself, so that we have a sense and defining it, is the ability of someone to obtain, process, and understand and communicate health-related information when they're making an informed decision. So this can affect a lot of other aspects. And it's not, see here, it's not solely the person who's receiving care. Health literacy impacts caregivers, family members, all of our understanding about how important sleep is for our brain health moving forward. 1/4 of the United States has low health literacy. So already just going into the interactions with patients and with your community members, regardless of the medical condition in the area, it's likely that 1 in 4 of those patients, and or even if the patient has good health literacy, we don't necessarily know how that's going to be impacted by the medical condition they're at, and their caregiver that's with them or the family member that's with them that's going to be there to support may very well have low health literacy. So there's a gap in assessing and explaining what's going on. Within neurologic disorders, it's been seen that there's low health literacy at high rates across different medical conditions, and there's impacts to outcomes specific to those medical conditions and areas within neurology. So there's going to be nuances within the many conditions and specialties that you go into. But so it's important to take a look at and understand what aspects are impacted, but it's something that we all have to deal with, regardless of the specialty or your role as a healthcare team member, caregiver, or someone's family member. As I said, these fall into kind of the socioeconomic position and aspect. So health literacy is not dependent on the medical condition. It's not dependent on the person's health status before they came into your hospital or the clinic, the condition you diagnosed them with, or potentially it could be impacted by how they leave. You could imagine how someone's level of cognition and awareness could be impacted post-stroke or post-traumatic brain injury. So having an assumption of their previous educational attainment and their ability to use the healthcare system could be significantly impacted moving afterwards. But other aspects that have been seen to impact health literacy. So age, education, race and ethnicity, and poverty. You can see all of those fall into areas that are socioeconomic aspects that are going on. So it's not, we want to make clear here that we're not blaming that someone because of their age, older, younger, has lower health literacy, that there's aspects socially and culturally and structurally in our society that have set them up for having lower understanding of health aspects and health concepts. Some things that impact in terms of outcomes in terms of health literacy. So lower health literacy in people with epilepsy, that's the PWE acronym, has been associated with poorer memory and information processing related to anything that they interact in life. So let alone understanding when to take their medicines and manage their condition. And then difficulties with self-care are associated with lower health literacy in areas of dementia, chronic pain, headache. And lower health literacy has been shown to have much higher rates of healthcare utilization, outpatient contacts, those EPIC messages, in healthcare utilization in terms of emergency room visits, no-show rates, all of these have been seen to be associated with lower health literacy rates. Some of the things that contribute further to the gaps that there are in care associated with health literacy is this limited access related to culturally and insensitive care, the complexity of the medical language, which many of you are doing hard work to even understand on the first end, let alone when you come back to the other end and try to explain to your family what you do. Imagine the context of the 15-minute visit. Or all the things that you'll see are the challenge of explaining to someone as they're being discharged from the hospital. We can all understand whichever side of the bed or the curtain we're on, many of the reasons why there's many impairments in health literacy around many conditions, but particularly something as significant as brain health impacting so many aspects of our life. And then even if you know the right thing to do, put down the phone, turn it off, wind down your evening and go to sleep, there's the intricate brain and behavior aspects of how often are we doing that consistently, even if we know it's the right thing to do for ourselves. And all of that being overlaid by, as we've mentioned already, the socioeconomic and social determinants of health. So what are some things out there that can help us? So the AHRQ produces and have most recently just updated a whole health literacy toolkit that will help you take a look at materials that you're developing or that materials that you have that will also give you tools in improving your own communication with patients. Then hopefully, and as long as they exist, the Office of Disease Prevention and Health Promotion, also within the Department of Health, has a whole section on improving health communication and culturally competent care, but within that also a section of resources that are out there and available related to health literacy. So these are things that you can go back to specific to the areas or the conditions or the communication that you expect to help you work on improving your communication. Just like we have a lot of time that's spent on the Krebs cycle, within neurology, on determining whether or not something is a spike or a sharp or a seizure. Within physics, the states of light. If we're spending that amount of time understanding those, we should spend the time to also understand improving that actual communication with our community members, our families. And, some key things in considering in that communication that we have with patients. The patient and the family member are the ones who are going to carry through all that information you gave them into the home, into following up. And so they are a core member of your team, and including them on bedside rounds, including family members who are in the room in that discussion. If you are having handoffs, often as much as you can, including the patient or family members as a part of that handoff, can help reiterating a lot of the information that's occurred, providing them tools and information and resources to go back to, because we all know the limited amount of information you get out of a single lecture. Imagine how difficult it is for an individual learning a whole new medical condition, learning that they have not just high blood sugar, but they have diabetes or epilepsy, and maximizing how much we use lay terms. And so what I want to move forward then now is to take a look at within neurology, within neurologic conditions, within kind of topics around brain health, the idea of maximizing lay term and lay communication. One question would be what resources are as even us for patients to look at, find that information, but to show us examples of understandable, readable lay terminology that the community can understand. And it's an effort that has been part of the American Academy for some time. So in addition to the medical education and medical science journals, they produce a public and community-facing resource called Brain and Life. It started as a magazine under a different name for a bit, but that's just history. And then it turned into Brain and Life, and then it has a website. And more recently, in the last few years, we started a podcast, and then there's a book series specifically within conditions. Within the Brain and Life magazine, each magazine that comes out every month, there is accessible articles that are engaging. There are often a celebrity or a community feature for the cover, just so that there's a recognizable face to draw people's attention to. There are often 2 or 3 wellness articles on topics. These are some examples from the recent issue that is currently out. There's a disorders update, often talking about research or understanding and information or how a diagnosis is made or relative to a certain condition. They talk about safety issues and articles within that. Brain Wonders is a category that sort of just tries to tease people into ideas and the amazing ways the brain or the neurologic system works. This month's release was related to explaining what is a condition called sunflower syndrome. Exercise, and there's always a highlight on exercise because we know its level of importance related to brain health. And there's also other aspects, typical questions that patients have, or often questions that have been submitted by patients are posed to a neurologist and for a lay level discussion within the magazine. Within all the magazine content that is then archived into the website. So it's also available over time. And then there's added content that goes onto the website for patients and family members. But what's good also is the concept and the idea of using these kinds of resources as an example to you. If you're looking for how can I explain epilepsy, or how can I explain driving limitations to populations from different states? How can I explain the importance of sleep in a very lay and clear way? These articles can be a reference that's written at a very readable and approachable resource. And then there's the idea of how do I actually do that in conversation? So the podcast was released about almost 3 years ago now. And this was to answer the fact that not everybody's actually going on either websites and these wellness websites or reading wellness magazines that tend to skew towards older audiences and a predominantly white audience, and trying to leverage uses of podcast platforms and YouTube to see if we can broaden the community and the audience, along with starting to make an argument for making at least a quarterly episode in Spanish. And so since then, we've released over 152 episodes. And again, these episodes, we have a discussion with someone living with a medical condition related to neurologic conditions or brain health, and often a medical expert discussion where we try to reinforce a lay level discussion about that management of the medical condition, about life with it. We have sort of a story arc, about 6 to 8 episodes around medical conditions. So sometimes kind of like just the disease 101, topics about management. And these are all then resources that you can both listen to as a medical provider or share with your patients. They have a new diagnosis and they want to hear the stories of someone living with Parkinson's, its management. How could someone with Parkinson's row 2,800 miles from California to Hawaii and still manage their symptoms? That was this week's episode. And a lot of the episodes we've done in collaboration with advocacy organizations. We don't want to limit the voice to just the organization, but actually going to patient advocacy organizations and patient community organizations to amplify their voice, messaging. The American Heart Association came out with the Spanish version of the stroke identification as Rápido. And so we released alongside them a Spanish episode, talk about Rápido, to play the song that they developed with community members. And so there's been several episodes that we do in that. And we're not alone. There's many other neurologists that are out there trying to amplify exposure to the voice about brain health. And generally, we work to provide information in multiple formats, address health literacy issues, and connect with diverse communities through a lot of this public health communication efforts and the variety of episodes that we've had. But I wanted to take the time and thank again Dr. Etienne for his time and investment in all of us, including myself, and to come back to the memory of why we often are here, or all of those that stood behind us. I like to acknowledge the love and the time of my abuelitas that are now all passed from different types of dementia and other medical conditions, and the family that has been behind me and supported me along the way. And thank you all again.
Wonderful talk. Just stay up. We'll take some questions. Thank you very much for that wonderful talk, Dr. Correa. Just a couple points that stood out. I'm not going to summarize everything, but talked about making sure that as we engage with our patients, understanding, what are the determinants of their health, which are Dean Schluger always talks about that, and not limiting ourselves to just the social or structural determinants. Talked about the curb cut effect, how oftentimes when we're targeting a marginalized group, it might actually affect all of society, where a lot of us will actually benefit. And then, of course, the importance of communication and educating our patients. And you give lots of great examples. So really, really great points. We're going to take some time anybody have questions for Dr. Correa? So this is crystal clear. If I give you a pop quiz, you'll get it all right. Get 100%. All right. I think you are dismissed. Our military days. Thank you very much. All right. Thank you, Dr. Correa. Great work. Really inspiring. Really, really wonderful to see all this wonderful work. This year, we normally have one keynote, but this year we actually decide to do a dual keynote talk because of the topic. And really, we were fortunate that Dr. Shroy Lesnick from our diversity and inclusion working group had a great contact and was able to get us this one of our speakers. I'm going to introduce now Vinnie Bagwell, who is going to be speaking about the history. Making History is the title of her talk. Vinnie Bagwell preserves African-American history by creating art for public spaces. She is a 2022-2023 inductee for the Who's Who in America for Sculpture. A representational figurative artist, Vinnie uses traditional bas-relief techniques as visual narratives to expand her storytelling. Vinnie's most recent notable pieces, entitled Victory Beyond Sims, is a $1 million public art commission that will replace the J. Marion Sims sculpture on Fifth Avenue at 103rd Street. The creative genius of Vinnie Bagwell's work gives voice to our stories and meaning to our legacies. Ladies and gentlemen, Ms. Vinnie Bagwell.
Good afternoon. You folks up there in the nosebleed seats, hi. So, history is the memory of people. And I am a maker of art. I am untutored, gifted, as they used to say when I was a kid. I draw, I paint, I sculpt. And the thing of it is that I'm a storyteller. And when I first began sculpting, by the way, this sculpture is my 7th sculpture in the first 7 months of sculpting. I'm just playing, and this is what I'm making. I realized that representation matters in storytelling. As an African-American woman sculptor, I bring cultural experience and insight that deepens the authenticity of the narrative. And the fun thing about history in this country is that Black people have been marginalized in so many ways that even we don't know that we've been marginalized. So when I first started sculpting, I looked around my town and all I saw was dead presidents and war heroes who live in Yonkers. And so that made me understand the importance of ensuring that the artwork resonates emotionally and intellectually with diverse audiences. This is the beauty of living in New York. It's diverse here. So I'm used to talking to different people. And again, the idea is to make permanent art that speaks to everyone at the base level as a human being. And so the HeLa Conference, of course, aims to address issues of diversity, equity, and inclusion within the medical and scientific communities, focusing on contributions and experiences of marginalized groups. So in 1994, I wrote a proposal to the city of Yonkers to do Ella Fitzgerald because Ella Fitzgerald is from Yonkers. She grew up there. She is an international music icon, and she transitions race. White people love her, Black people love her, people all over the world love her. And so City of Yonkers said yes. And so Ella Fitzgerald is at the Yonkers train station. So my work focuses on marginalized history. And so the public artworks that I create contribute to this mission by fostering a more inclusive historical narrative that recognizes the critical roles Black women have played in advancing medical science, often without their consent or recognition. These works are designed to foster connections within the community and its history. I do want to say about Victory and about the fact that this sculpture is what will be replacing his sculpture. J. Marion Sims was experimenting on Black women in the mid-1800s when white people said that Black people were 3/5 human. And so when you think of things like, for instance, the Hippocratic Oath, which says, not literally, but in a way, first do no harm, this, I imagine, did not occur to him because, again, it was the tenor of the time. So the fun thing is that fast forward in 2009, the communities of East Harlem, Harlem and Upper East Side realized the implication of his sculpture being on Fifth Avenue, and they spent 10 years getting that sculpture taken down. And then they, of course, created the commission to replace it. And I'm happy to be working on it. It's taking a really long time to get through final design approval, but we are making progress. And so my job revolves around the celebration of the African diaspora through my unique blend of artistry and storytelling and advocacy. I am somehow reshaping public art to reflect a more inclusive and accurate representation of history and culture. For instance, Harriet Tubman was 29 years old when she was running the Underground Railroad as a conductor. But most people think of her as an old woman, but that's not what she was doing when she was old. She was 29. And so, you know, when I got this commission, this is for Niagara Falls, it's going in this spring, it was important to me that she be young because I want her to appeal to young people, because you don't have to be educated, you don't have to be old, you don't have to be learned to make a difference in the world. And that's the message that I want to tell with this sculpture. And so across the country, my sculptures serve as teaching tools, bridging the gap between history and contemporary relevance. When I was in high school, I didn't care about history. I really didn't. I got a C in history because, well, my history teacher was boring to me. And so I find it really ironic that, you know, my life now revolves around telling stories about history, but I want to make the stories good. I want to make the stories relatable. And so the beauty of these works is that they are accessible. The fun thing is that you can see these sculptures 24/7. You roll up on it, and when you leave, you know something that you didn't know before you got there. And so again, the goal is to create destinations for non-traditional interdisciplinary teaching approaches. I call them outdoor museums. And so we're talking about the role of enslaved African women, and it's important to understand because of the ethical, cultural, and scientific foundations of modern medical practice, as well as recognizing their resilience and contributions to society. If you get a chance to go to Yonkers, the Enslaved Africans Rain Garden is down by the pier. There are 5 public artworks that celebrate the first enslaved Africans to be freed by law. 6 of them came from Westchester County. And so the fun thing is that enslaved African women's use of medicinal plants informed early medical practices, particularly in treating illnesses and injuries. And African traditions of inoculations against things such as smallpox helped to shape early vaccination efforts. This method, introduced by Onesimus, who was an enslaved man, was also practiced and passed down by Black women healers. And these women brought traditions of midwifery to the Americas. It's a funny story. I sent my daughter to Parsons School for Design. She's more gifted than I am. Got her through Parsons. She got a really great job. She came out of Parsons, and her first job was senior graphic designer for Penthouse magazine. Somehow Penthouse had become a rag, and she fixed it to the point where somebody bought it. And on the day that they bought it, they fired the whole New York office. And then she got plummeted into unemployment for more than 2 years, which freaked her out because this is a chick who told me she didn't want to hustle for a living. I'm like, grown-ups don't want to hustle for a living. None of us want to hustle, but you know, it's a necessary evil. But the point of it is, as I said to her, you may have to find something else to love because artists need to love their work. So she comes back to me a month later and says to me, would you be mad if I weren't an artist anymore? And I said, that's impossible. It's like saying you're not a woman anymore. I mean, that's possible, but I mean, not really. And so I said, what are you thinking of? And she says, well, I want to deliver babies for a living. I'm like, med school? Like, I just got off med school? Like, you're paying for that? And so she says, no, I want to be a midwife. I'm like, a doula? She's like, no, a midwife. I'm like, oh, excuse me. At any rate, to make a very long story short, my daughter is a midwife. And she considers that to be a quote unquote sustainable job. She's very good at it. At any rate, enslaved and later, of course, emancipated Black women were often midwives, and they were ensuring the survival of countless mothers and infants. And of course, because my daughter is an only child, I get the daily blow by blow, what's going on in labor and delivery in her hospital in South Jersey. And she's seeing, and I'm hearing about the disparities in medical practice between Black people and others. So it's a real thing. These midwives, their techniques influence public health approaches to maternal and child care. And many enslaved women served as wet nurses and caregivers. This is Sojourner Truth. She was a nurse during the Civil War, which is kind of interesting to me. And so these people provided medical care to both Black and white communities, despite lacking formal recognition. And their hands-on experience contributed to the developing of nursing as a profession. And again, my mother's a nurse. And the fun thing about her is that when I was a kid, she wasn't a licensed nurse. She was just a practicing nurse somehow. And she was the nurse of choice for the who's who in Westchester County. I mean, she was night nurse for the Bloomingdales, the Strausses of Abraham and Strauss, the Farberware family, Joan Rivers' dad. I mean, there was a whole plethora of who's who in Westchester County, and they needed somebody. They called my mother. At any rate, enslaved African women played a central role in advancing gynecology. Of course, as we spoke earlier about J. Marion Sims, there were 12 women. Oftentimes they talk about Anarcha and Lucy and Betsy, but there were 9 other women who are nameless, but that doesn't mean that they shouldn't be acknowledged because, well, they contributed equally. So thus, Victory, we shortened the name. Originally, the name of the commission was Beyond Sims, and we were calling it Victory Beyond Sims, but now, because so much time has gone by, we all just call her Victory. That's now the name of the piece. Victory replaced the sculpture of the J. Marion Sims that was removed from Fifth Avenue in Manhattan. And this artwork will acknowledge the suffering and the fortitude of these women who laid the groundwork for many of the advancements in obstetrics and gynecology. Of course, we have to talk about Henrietta Lacks, a Black woman who unknowingly contributed to modern medicine when her cancer cells were taken without consent. This is 1951. And again, you have to put these stories in the context of time because, as it was said earlier, the tenor of the time does make a difference on the perspective. And so, of course, Miss Lack's cells became the first immortal human cell line, and they were used in groundbreaking research, which, of course, includes development of vaccines such as polio, cancer treatments, and in vitro fertilizations. By the way, this is the piano for the 2012 version of the piano lesson at the Signature Theater on Broadway. Ruben Santiago Hudson was the director of that play. So many African-American women, such as Mary Eliza Mahoney, who was the first Black professional nurse in the US, and Dr. Rebecca Lee Crumpler, who was the first African-American woman physician, these women broke barriers in healthcare, paving the way for future generations of Black medical professionals. Recognizing the exploitation of enslaved Black women who were often erased in medical history allows for an honest examination of ethical failures in medicine. And by amplifying the voices of marginalized communities and confronting past injustices, it calls for ethical medical practices that respect bodily autonomy. It also highlights their brilliance and acknowledges labor as a foundation of medical progress. Understanding this history sheds light on the ongoing disparities in healthcare and the mistrust many Black communities have towards the medical system. It underscores the need for equity and trust in healthcare, especially for communities historically marginalized or harmed by medical institutions. Unfortunately, these biases still exist in 2025. Thus, addressing these issues is crucial for improving health outcomes. African-American women's contribution to medicines through lived experiences, knowledge systems, and activism reflect their agency and cultural wealth. This history enriches the narrative of medical innovation. Learning about these contributions empowers new generations of Black women in medicine and science, inspiring them to continue breaking barriers and driving progress. Shout out to all my students out there. My artwork advocates for diversifying public art and challenges the traditional norms of public monuments, bringing more inclusive stories to the forefront. And by highlighting these stories, both the HeLa Diversity, Equity, and Inclusion Conference and I work to promote a deeper understanding of past injustices and encourage ongoing dialogue about ethical practices and equity in research and healthcare. My last story. These two people are important. I get a phone call one day from the gentleman, and he announces that he's the 5th generation grandson of Sojourner Truth. I'm working on a sculpture of Sojourner Truth. He wants to know, can he come over? I'm like, okay. And I thought he was joking, but it was real. And so it was really interesting to find out that Sojourner Truth's family is littered with artists, a lot of painters, good ones. I also found out that, and most people don't know this, that Sojourner Truth's family is married to Malcolm X's family. And it's like, wow, that's really interesting. So at any rate, I gave a party for him and the family when, I was finished with the sculpture before it went to be cast. And then I get a phone call from this woman who is 6th generation niece of Harriet Tubman, and she's mad because I didn't invite her to the party. And I'm like, I'm sorry, do I know you? Do I know you? And she says, well, we're Facebook friends. And I'm like, no, do I know you? When we became Facebook friends, did you tell me? I mean, because sometimes my memory not really good, but I'm thinking I would have remembered that. And she's like, well, no, I normally don't say anything because I don't really like to draw attention to myself. I said, well, then you can't be mad. But okay. So at any rate, I gave a party for the two of them to get together because, they wanted to meet. And so this was part of that, this moment. At this point, I'm working on the Harriet Tubman sculpture. At any rate, it is an honor and a pleasure for me to do this work. And I really want to thank you for inviting me to speak. And I'll be happy to answer any questions.
Thank you so much. That was amazing. Thank you very, very much for sharing that.
Thank you.
Amazing history, great storyteller.
Any questions?
And we're going to take some questions. I was thinking of a joke to say about the C you got in history you talked about, but you clearly get an A+ today.
Yeah,
It's
history
awesome.
is interesting, because you realize that people are people at every point. It doesn't matter what year. People are people, and we are making history now because in a minute we will be history.
Yeah, no.
Questions?
Excellent.
Anybody?
Yes, anyone with a question? I'm
Yes.
sure there must be lots of questions.
Hi, I'm gonna take you first. Go ahead.
I'll go first. Okay. Hi, my name is Patrice Gordon-Poyser, and I just have a question about the role that you play in advocating for and commissioning your pieces. I know you're the sculptor, but do you take an active role in making suggestions of pieces that you think should be placed in certain communities to ensure that there's representation via artwork, specifically your artwork?
All right, let me qualify myself.
Yes, please.
I have to compete to make a sculpture. I have to win. My real job is compelling people to say yes to me. So I don't come up with good ideas or great ideas. I come up with winning ideas.
Yeah.
I have to win, which means I spend a lot of time researching. There's always a psychology to my concepts. The bas-relief technique, which is kind of like that, what goes on a quarter. Okay, the bas-relief technique is narrative. To me, it's not important enough to have a pretty sculpture in a public place. I'm trying to inform the viewer. I want anyone who rolls up on it to know more than they did before they saw it. And then what I really want to do is I want to not just snatch your eye, I want to hold your eye, I want to make you look. And then the question is, how long can I make you look? And in order for me to do that at the level that I'm doing that, I have to really understand humanity. To spend a lot of time thinking about myself, as well as what it means to be Black, as well as what it means to not be Black. Because I don't care how much Jessica explains to me what it's like to be in her shoes, I'm not like her. All I can do is go on what she tells me and try to imagine. It's the same thing about being Black, okay? When people try to say that they understand, you can't understand if you're not Black. The best thing I can do is to try to give you as much information as I can to compel you as a human being to do the right thing, to be a good person, to be kind, I mean, there's a whole lot to it. And, you know, for the most part, I only apply to things that make me feel like, oh, that's mine. I claim that. That's mine. And I'm here for that. And so, of course, the fun thing also, too, is that let's just talk about representational figurative art. Talking about looks like you, is you. In this country, there are only about maybe 6,000 sculptures like that. 95% of them are done by white men. Less than 5% are done by women, and even less than that are done by Black people. So when I chose to get into this work, I came with the willingness to fight about it. Oh, I'll argue with it about it. And again, it's not even about overcoming you, or battering you. It's about trying to explain to you the merit of my story, why my story matters better than anybody else standing here, because I've done the work.
Yeah, no, amazing. And that made me just think of something, when you said that the work you're doing, 95% are from one demographic. And then despite that, you're still pursuing it. One of the things we see a lot in medicine is that we often will have students, it might be a woman who wants to become a surgeon, for example, or a neurosurgeon, where when they go into the OR, everybody there is a man, maybe one woman in there, or some of our African-American Hispanic students who are trying to get into a field, and they might feel like the door is being closed. So what's your secret to saying, well, you know what? I don't care how many of this or that is there. I'm going to put my stake in there and still get what I want. And
Okay,
if you could give these students the advice that people are
I had to go back a little bit, because I went to Greenberg Central 7 public school system, went to Woodlands High School. When I went to high school, 8th grade was high school. And on the second day that I was there, the English chair assigned herself to me. Oh, you're one of the smart ones, she said. She said, well, I'm going to be your mentor. And that woman challenged me to take 2 English classes every semester. I took 10 Englishes. So I took New York Regents AP English, and then I took critical thinking, expository writing, creative writing. I mean, Woodlands High School had a phenomenal English department back in the 70s. So by the time I got to senior year, I was a writing athlete. College was easy for me. When I came back, I went to Morgan, a historically Black school. I went there because my girlfriend said I should go to a Black school. My parents didn't know. I was the first one in my family to go to college at that level. And so this is during the era of Black power. It was the first time when we first went natural with our hair, when we first did cornrows, we were into like this. And so the point of it is that I went originally with the intention of being a therapist. I thought I was going to sit around and solve people's problems. And senior year, I was like, I don't really want to do that because people don't listen. And I didn't want to spend my life being aggravated with people who just wouldn't do what I said. So that was how I felt about it at the time. So, I had a mentor during college, and he was the psychology department chair, Dr. Carter, God bless his heart. And he knew that I was an artist, and he didn't understand why I wasn't doing art. And it was because my mother told me that I couldn't. You can't make any money doing art till you're dead. That's what she told me. I get a lot of pleasure out of telling what I won lately. But the point of it is that I don't know what they teach at Morgan now. I assume it's probably the same thing, but I was taught over those 4 years that mediocrity was not acceptable. When you're Black, you can't be mediocre if you want to do anything. You're going to have to work harder, longer. You're going to have to go the extra mile because you're Black. That's what I was told at Morgan State University. So I came out of there believing that. But at that point, I had resolved that I really was going to try to do art. And so I found another mentor. Harold D. Sanderson lives here in Elmsford, 20 years my senior. And I mentored under here. I believe in mentorship. Find yourself somebody older than you. Don't be stuck on people's ages or what they look like. They don't have to look like you. It could be somebody that looks nothing like you. You go at the soul level. You find somebody who has the same passion, same interest as you, and you ask them for your help. Most older people, if they're nice, are happy to help a young person because we've already been through the fire. We already know the off-road path. And by the way, our path might not necessarily be your path, but we got ideas about how to get to, quote unquote, the mountaintop. And so the point of it is that Harold, being a West Indian man, raised in Harlem, he too talked blackety black to me. And it was about uplifting the race. We used to give Black businesses discounts because we made them look as good as they were. They didn't really have money for graphic design services. We weren't inexpensive either. But the point of it is that we had a commitment to uplift the race by making them look presentable because they were doing the work. And then fast forward one day, I realized I had a painting block. I hadn't painted for 7 years. I'm a really good painter. I couldn't get myself to do it. And it's mostly because I don't have a technique. I just kind of do stuff and it happens. That's how it happens for me. And so the point of it is I tried sculpting, and really by the time I got to the 4th or 5th one, I don't want to do a big one. I started looking around. And again, I think the thing of it is that you need to find something to love. Tell you like I told my daughter, find something to love, something that you just think is, pardon my French, the shit. That's what you're here for. This is what my life, find yourself a purpose. Find yourself a purpose. It don't even have to be your work. It could be something else. But find something that you feel makes your life worth living, and then do that. Or figure out how to do that. You don't have to go to school. I mean, school is nice and certainly has its place, but you don't have to be in a classroom. You can learn it in the street. That's what I was told. And so there's more to learn in the street than there is in the schoolroom. And that's why I went with mentors. And again, the question is, what's going to make people say yes? I started sculpting before we had the internet. That's how old I am. I was living in the library with the Dewey Decimal System 3 days in a row. The third day, I found out that there are people who will give you money because they think that artists shouldn't have to be encumbered with bills. I cried. Like, whoa, really? Paul Krasner Foundation still gives $30,000 a year every year to an artist they feel is worthy. I did not win that grant, but it made me feel like there is somebody on this planet that cares about what I care about. And since I see a place for me, there is a gap, there is a void. There's no voice for Black people. Everywhere I went, I'm looking. I mean, even now, when I go to a new town, it's like, what they got here? Oh, they got what I call plop art, stuff that means nothing. You know, like when you go to White Plains, you got the grass blades. It's like, oh, okay, it's pretty. But, you know, it unnerves me when I go someplace like, oh, I don't know. How about Hilton Head? Went to Hilton Head, they called me down there. They had zero public artworks about any kind of history, never mind Black history, any kind of history. It's like, so you want people to think you just woke up like this? Well, I mean, you know, and again, history is the memory of people. And the way that things are going in this country, the work that I'm doing is important because you're not going to necessarily see Black history in the curriculum. You know, you got movies, but, you know, movies come and go. Public art is for a couple of 100 years. It's permanent, unless somebody just decides to dig it up out of the ground. But the point of it is that I get to say something, I get to speak for my race. It's an honor. And I take it very seriously because it's an important job to do. And I'm just simply saying to you, find a job that you feel matters to you that helps other people. I mean, That's part of what being a doctor is going to be about anyway, but find something specific in your specialty that it make your heart go boom, boom. And then work that however you see. Because again, I roll up on the regular. Last year I was a finalist 10 times. I won 5 out of the 6, which normally I do better than that, but 5 out of 6 is not shabby. I'm competing against the entire country on a regular basis. That's all I do. I don't have no real life. My life is all about the work. The point of it is that I don't mind, because at the end of it, I can't tell you what it's like when people you don't know tell you they love you and they love the work that you're doing and they welcome you. Like, if you come to my town, you have to stay at my house. I don't know these people and they mean it. I'm at the airport this past weekend and this woman says, I know who you are. Mind you, I asked to get off the plane. The plane was sitting there for 40 minutes. I was going to miss my connecting flight. I was like, I have a press conference tomorrow morning. I am not going to be able to make it. I would like to get off the plane. May I please? And they let me off. But the point of it is, the woman who met me at the door, when they let me out the plane, she's standing there like, Mom, like this. What is your problem? And I told her. And as she was canceling my flight, she said to me, oh yeah, by the way, I know who you are. And I love your work. You keep doing what you're doing. To have that kind of affirmation for your work, it's priceless.
Amazing. Wow. Excellent.
Other questions?
Yeah, we have time for, okay, I think, look like you got somebody motivated there. Come on.
Yeah.
You can come to the mic, please.
Oh, I have it.
Okay, great.
It's an honor, really, to be in your presence, especially with the work that you do. My question is, of all the pieces that you've created, which is the one that tugs at your heart every single time you see it, the one that matters to you the most?
You mean the ones that are actually done or the ones that I want to do?
The one that, it could be either one. Both.
Let's go back for a second in here. I love the griot. This did not win. I was really surprised that this did not win. I made it for Richmond, doing a slave memorial. And if you know anything about Richmond, Virginia, it has a really nasty history when it comes to slavery. It's nasty. Like Norfolk, nasty. Like when you read the story, it's like, dang, like, wow. So Richmond decided that they didn't want us to talk, they didn't want, the finalists, there's 5 of us, they don't want us to talk about their history. So of course, I do these things all the time. So I smile like, yeah, okay, let's see, what do they want us to talk about for real though? They're like, we want you to talk about what Black people were from Africa before colonization. I was like, how much money do you have? Okay. So we have a budget, and the thing about public art is that you have to work in the budget. You just can't tell them I need another million, or I need another couple of 100,000, or I need another 50. No, this is the budget, okay? So I do people. So I'm sorry that I don't have any other images of this, because this is really cool from the side, but this is a griot. A griot is a person whose job it is to tell the stories of the tribe. This is the repository for the history. They don't write nothing down, everything's oral. And it's funny because in this country, Black history is mostly oral. We know our history. Black people may not know all our history, but we know our history, and we're still learning our history because a lot of it, again, is marginalized. So this piece has all this bas-relief on it that covers every single thing. So guess what? So who created math? Who created pharmacology? Who created medicine? Who created astrology? Who created astronomy? Who created agriculture? Who created the mother? They don't call it the motherland for nothing. Somebody's going to buy this piece sooner or later. I'm going to see to it because I'm going to offer it again. So hi, this is my favorite piece that is not made. By the way, last year I got into digital. I can sculpt with my hands. But when it comes time to enlarging, I have to hire an engineer that makes the big one for me, and then I finish it. That is a very particular skill, and I'm here to tell you it's a lost art. So now I have to do digital, and this is the fun thing about aging. If you're gonna work after you get old, you need to stay relevant with what's what, okay? So AI and ZBrush. This is still my style. This is still that still looks like what I do, but this sculpture, I haven't seen it in the real world yet. It's digital. When I find the money, if nobody buys it, I will print it out and cast it in bronze. But for now, it's no longer just in my mind. I can show it to people and hopefully close somebody to buy it. Let's see how that goes. You'll see. This one too, as well. This one I'm working on now. This is for a slave memorial for Kentucky, Lexington, Kentucky. It's going to a plantation. And again, the plantation is now a museum. And they want to celebrate the enslaved Africans who built that wealth. They just had, this is the press conferences I missed on Monday. But again, it went very well. And, they called me because it went really great and we got some donations and, we're going to meet our goal and we're so excited. And I'm like, great, because this piece will become real. Look for it. After that, I could pick anyone because this is 6. I use this as my avatar. If you see me on social media, it's always this. I don't change my profile picture. This is my 6th sculpture in the 6th month of sculpting in the 1st year. I was like, God has changed his mind. He's like, forget graphic design, forget writing. I was a newspaper columnist at the time. I write very well. God said, no, forget all that. Here, I got something better for you. You're going to love this. No ramp up time. We're just going to make sculpture. That kind of gift in the middle of your life really make you stop and think about who you are and what you're doing here.
Somehow I suspected when that question was asked, because these are all kind of like your babies, you gave a actual mom answer, which is I love all of them.
Yeah, for different reasons, but
Yes.
it's phenomenal. Anybody else before I go? Thank you.
All right. Thank you
Thank
so
you.
much. Wonderful. Really amazing. Amazing that we have you right here in
I'm in Yonkers, yeah.
Wow. Thank you once again. That was just absolutely amazing. You want to, for our next speaker, I'm going to ask my good friend, Dr. Shrante Girardi, who is the professor and chair of OBGYN, to do the introduction.
Thank you very much for that presentation. I'm live by Central Park, so I'm going to look forward to looking at that beautiful work that you will do. I want to thank the opportunity for us to be able to introduce Dr. Farrow. But before we do that, I wanted to reflect on a couple of things in the department. I have the bounty and pleasure and privilege of serving in the Department of OBGYN. And we talk about history all the time, and everyone is hopefully becoming more and more aware of the history of gynecology and Marion Sims. But part of the reason for history, it is hoped that it informs us to rewrite history differently, at least for our time. And the hope of this department is through some of the efforts that we're engaged in is that 100 years from now, hopefully the history that we're helping to write will be quite different than from the past. And it won't be a history that will haunt us all the time. Because if history does not inform us into an action that's more reflective and thoughtful and change-oriented, then I'm not sure what the actual function of history was and how do we take it. So to that end, the Department of OBGYN here at New York Medical College and at Westchester Medical Center made a decision collectively that if you look at the history of gynecology, we think that this is a distant history. Unfortunately, the current president of the United States has the highest rate of maternal morbidity and mortality in the last 65 years. We spend close to 20% of our gross national product on health, and we register some of the worst outcomes for women, particularly for Black women in this country. So yes, history has changed in some ways. Perhaps we give anesthesia, but boy, we still have a very painful present that is going to write a very bleak history if we don't
turn the tide of that. So we don't always cause sea change, but we certainly cause drop changes that will become sea changes in the future. So the Center for Women's Health Equity was founded here at the Westchester Medical Center and New York Medical College with a $750,000 grant in 2023. And I want to really address that everybody here has really been a partner, particularly my dear friend Mathilde, Dr. Etienne, and obviously under the leadership of Dr. Schluger. And in that process in the last 2.5 years, it's really changed the whole entire department because it's focusing on 5 pillars: integrating of our care systems, that a woman who's got hypertension and has a 4-fold risk of death as a pregnant woman doesn't have to go to 15 appointments. And the reason why they die, 50% of them 6 months after delivery, is because no one cares about them anymore. They've been an isolated event of intervention and success for the institution, but we didn't really help change the arc of the life of that woman. And we fail in that all the time. So ours is to rethink the way we integrate those services. And perhaps we cannot change the tides of racism that happens around the world, but we surely can change that in the context of our work and in our department. The next one is actually to change the future of curriculum for our residents and students so that we inform the next generation that they will only think about the time that we registered the highest rate of maternal morbidity and mortality, that 1 out of 4 pregnant women with hypertension die in the United States, that they build it differently. Community partnerships, and really not as here's a behemoth coming in to show what we have, but as genuine, humble posture of learning and approaching the communities and saying, let us actually hold each other's hands and do something a bit different. If we discover great discoveries as we do in this medical school and we fail to deliver it, that's a major failure. Discovery means nothing without access, without delivery. The last bit is on advocacy, but advocacy has to come from a place of action. It can't just be words. And more importantly, research that we do ought to become a population-based research that answers the question of the population that we serve and answers the question of the people that we have the bounty and privilege of serving. And that has really transformed the department in thinking about itself and its why completely differently. That no longer do we exist just for headlines, but in our actions, and let our actions and our deeds be our adorning, not our words. And so hopefully to that end, we managed to get another 750,000 and total of 2 million. And we drove the C-section rates in our population by over 50% for the first time to meet the 2030 goal. So things can happen not just beyond words, but by really having a selective thought and concerted effort. It has changed the way we view ourselves. It has changed the unity of the department. I believe that with the leadership of this medical school, we will put health equity at a greater sort of stance. When there are forces that wants to counter what health equity means, ours is to stand tall and to stand firmly rooted and continue to do so. So to that end, it is such a privilege today to introduce our speaker, Dr. Monique Farrow. Dr. Farrow has been involved in, and I'll introduce a little bit more formally, but I want to talk about, we talk about women's health and obstetrics care, but if you look at the history of SIMS and all those horrific things that we learn about in gynecology, one of the biggest issues of access is actually access to safe surgical care, particularly for Black women. It is enormously difficult to find good healthcare, enormously difficult to find a surgeon who would operate on you the way they should operate on their family members, but they want somebody to operate on their family members. And to gain access, it is impossible maze for one to really conduct themselves. And imagine if you don't have an advocate or you don't know the system and perhaps not the best insurance, well, you do not want to be there. And imagine that 30 minutes of that, with all the distrust in the world, you're going to give somebody a permission to paralyze you and take a knife to your abdomen. It's a big deal. So part of our goal is to actually help advance a center for safe access to equitable surgical care in the region. And Dr. Farrow came and gave an amazing presentation to our department. She's a fellowship-trained, minimally invasive gynecologic oncologist. I wish you were a gynecologic oncologist. That's my job. You see, this was my attempt at a subliminal level to recruit her into my own division. But she is a fellowship trained minimally gynecologic surgeon. She's currently an assistant professor at University of Pennsylvania in the Department of OBGYN and the founding director of the Center for Integrated Fibroid Care, particularly with focus on access to underserved population. Her clinical research and programmatic project focus on addressing disparities in fibroid care, quality improvement, optimizing access to minimally invasive gynecologic surgery, and rewriting the history of all the awful things that we've seen before. Dr. Farrow graduated medical school from Washington University in St. Louis, completed her residency at NYU Langone Medical Center, and fellowship in minimally invasive gynecologic surgery at Northwell. She has previously served as an associate director for the fellowship program at NYU, and she is passionate about community outreach, surgical education, mentoring of future minimally invasive GYN surgeons, and changing the history. And we're really hoping and delighted that not only are you here to inform us, but help us rewrite that history. Welcome, Dr. Farrell.
Thank you, Dr. Tijrati, for that incredible introduction. And thank you for having me at this conference that feels even more relevant than ever. When I first accepted the invitation to speak, I thought, oh, I'm not a historian. I don't have a title in DEI, but I guess, the work that I do in gynecology does focus around access and equity. And I was even more excited to come here today after just sort of, the recent turn of events in this country. So we all need to continue to do this work. While unfortunately I still have no financial disclosures, I do think it's important for me to disclose my positionality, because I think that undoubtedly informs both the work that I do, how I see the world, how I move through it. And I think we all should do that as we take care of patients and as we do the work that we do. So I am a self-identified Black cisgender female. I am a gynecologic surgeon, as Dr. Tijrati said, not an oncologist, but benign gynecology. And I practice medicine at an Ivy League institution, which is wrought with all of its own, historical context, University of Pennsylvania specifically, in Philadelphia, which is the 6th largest city by population in the United States, where 40% of our patient population is Black. And this little, this black arrow here just sort of indicates where Penn Medicine is, where the blue color is Black population, and the other colors are white, Hispanic, et cetera. And you can see that Philadelphia is an incredibly segregated city. And so, we face a lot of the disparities that I'll talk about today when we take care of our patients. And so, again, like I said, I'm not a historian, but I do want to take us on a brief gynecologic journey to kind of understand the past, the story of gynecology, and sort of how that might inform where we are today, and how that then can transform into the future, and give you some examples of the work that we're doing in Philadelphia. And so, as Vinnie Bagwell mentioned, the history of obstetrics actually started with midwifery, particularly of Black women, but the history of gynecology in the United States actually started with 19th century white male surgeons. And while James Marion Sims, is likely the most famous, he was not the first and not the last. And so Ephraim McDowell first was the one to first successfully do an abdominal surgery where the person actually survived. And this was on a woman who had a very large ovarian cyst. And she lived to, I think, 70 or so. Thereafter, John Peter Mettauer actually performed the first repair of a vesicovaginal fistula. But James Marion Sims really developed the successful technique and really published a lot about this. So he's the most prolific and the one that we know the most about. And he is considered by many the father of modern gynecology, mostly because of his multiple experimental surgeries on enslaved Black women over the course of 5 years, which he published about. And as was mentioned before, there were many women. These are the 3 women that were named, but there were many women. And he published on the treatment of vesicovaginal fistula in the American Journal of Medical Sciences, and then went on to be, very prolific with the Sims speculum that is still used today in gynecologic procedures. But I draw your attention to this quote by Dr. Deirdre Cooper Owens, who is a historian who wrote a very interesting book that I'll reference in a minute. And she says, when we exceptionalize individuals, we tend to forget about the institutional structures of racism that already existed. So while Dr. James Marion Sims is, popular for the most popular for these experiments that we know about, he was functioning under an institutional structure of racism. And I think we have to remember that that's what we have to combat. It's not any one individual person, but it is the systems. And I think we will get the most progress when we address the systems. And so this is the book by Dr. Deirdre Cooper Owens, Medical Bondage, Race, Gender, and the Origins of American Gynecology, which I encourage many of you to read. It's an incredible book. And what she does in this book is talk about how, while the history of gynecology is born from medical exploitation of marginalized women, first by enslaved Black women, and she references subsequently poor Irish immigrant women, through various surgeries, fistula repair, cesarean sections, et cetera. Our history tends to focus on the accomplishments of these 19th century white male surgeons, but in her book, she actually centers the narrative of the women. And so if we think about, part of what Vinnie Bagwell has done, right, with sort of replacing the statue of Sims and acknowledging these women, we need to center the narrative of the women. The same way when we think about taking care of our patients, not just centering sort of our accomplishments, our inventions, our research, but the actual taking care of the women. And so this is an opportunity to reframe sort of the history of gynecology beyond sort of just upholding the actual accomplishments. And the American College of OBGYN actually back, in 2021, through DEI efforts, named ACOG Days of Recognition in reference to the 3 enslaved women who were named under the experimentation of James Marion Sims. And the goal is to uplift the contributions they were forced to make, to learn from the history of racism in obstetrics and gynecology, and to remember why it's critical to work towards providing inclusive, respectful, and culturally competent care. And I think when we do that, when we sort of incorporate, like we said, many have said earlier, DEI efforts are not just about, taking away from something. DEI efforts are about bringing different voices and bringing different perspectives, right? And one might wonder that amongst the 19th century white male surgeons, if there was a different perspective, that there might have been a different outcome for some of those patients, right? And so we think about that when we move forward into the future. And so I think a lot of that history of OBGYN, particularly gynecologic surgery, contributes to a lot of what we see today in our disparities in our specialty. So we really have to examine sort of the history of our specialty to understand kind of where we are. Things like prioritizing medical advancements and not the lived experience of our patients, normalization of female suffering, particularly the misinformation of the Black experience of pain, which was part and parcel to some of the explanations of why Black women, back enslaved women, didn't necessarily need anesthesia for some of those procedures that were done historically. And then the dehumanization of the Black birthing experience in the female body. And so these sort of underlying roots of what our specialty is, I think, helps perpetuate, unfortunately, some of the disparities that we see today. And one of those modern day manifestations we can see in obstetrics, Dr. Tajrati mentioned, maternal morbidity and mortality. And I draw your attention to the research around maternal morbidity and mortality as it relates to anemia. And the paper here on the top left references that 1 in 5 severe maternal morbidity and mortality was related to severe anemia in early pregnancy. And the study down at the bottom talks about how part of that may be explained by our guidelines, our race-based guidelines that defined anemia differently for Black women than for white women. And so using those race-based guidelines to diagnose anemia in pregnancy, they found that was potentially leading to poor outcomes for Black patients, right? So it wasn't any one particular patient's anemia, it wasn't any one particular practitioner's treatment of that. These were actually guidelines where this was built into there. And some modern day manifestations in gynecology, I think, as we talked about earlier with the cut curve effect, right? We look at pelvic exams under anesthesia. So this is a relatively common practice for decades, where a pelvic exam is part and parcel to a gynecologic procedure, and many patients didn't realize that they were having a pelvic exam under anesthesia. And this, on the right-hand side, is it's a guideline from University of Pennsylvania from 2003, a policy statement about pelvic exams under anesthesia performed by medical students. And in our institution, patients have to sign a dedicated consent form that they understand that they're having a pelvic exam under anesthesia, and they consent yes or no to whether or not they will have a medical student perform a pelvic exam. But this is not something that sort of happens across the country. And recently, in the New York Times, there was an article about HHS sort of recommending that patients, hospitals must get written consent for pelvic exams. And it had been studied that potentially over 3 million Americans are likely to have received unconsented exams, and Black patients were 4 times more likely than white patients to have received these exams. And I can't help but wonder if the underlying history of OBGYN, of gynecology, allowed for some of these blind spots, right? There not enough sort of diversity and understanding that this is not something that the lay public even knew was happening, and really understood that was something that they needed to consent to. So I think, we've made some progress in some of these areas and sort of trying to point out what are the issues that exist around, consenting patients, around disparities in care. And one of the areas that is more specific to the work that I do is in fibroid care. I'm a minimally invasive GYN surgeon. I take care of many Black women with fibroids. And while in OBGYN, we've known for over a couple of decades now that fibroids have an outsized impact on Black women, it's recently come into the public consciousness around sort of the disparities in how fibroids affect Black women and how the treatment differs. And just to kind of bring everyone together, fibroids are the most common gynecologic tumor, and they affect nearly up to 80% of Black women. And they present in various ways, abnormal bleeding being one of them, and that can be very challenging for patients to sort of discuss, what is abnormal. It's not a condition that people often feel comfortable talking about. If you have a pain in your elbow, people can sort of relate to that and say, yeah, I had a pain in my elbow once too. But sort of discussing pelvic pain and bleeding can be very complicated for patients. And it's a leading cause of hysterectomy in the United States, with annual costs in the millions to billions. And currently we know that risk factors, one of the main risk factors for fibroids is actually Black race. And while there's other risk factors that exist for fibroids, Black race remains at the top of pretty much every list when you look at risk factors. And with Black women having a 2 to 3 times increased risk of fibroids. And so in the work that I do, we sort of try to understand not only the disparity in sort of fibroid incidence itself, but kind of thinking about fibroid care, and how patients receive treatment. And when we did that, we sort of started with this CDC definition of this health disparity, which is preventable differences that are experienced by socially disadvantaged populations and are inequitable and directly related to unequal distribution of resources. And so in gynecology, we think about sort of the distribution of resources when it comes to access to minimally invasive surgery. And we kind of wanted to understand what can we do about this, and how can we move forward. And one of the disparities, like I said, prevalence and disease onset is higher in Black women. They develop at earlier ages. They have more severe disease. They have larger and greater number of fibroids with them growing longer, with more severity and symptoms. And we also, one area that is part of what I specifically look at is the treatment difference. So there have been studies showing that hysterectomy and other non-surgical options, hysterectomy is more common versus other non-surgical options in Black women. And Black women tend to undergo more open surgery instead of laparoscopic surgery, as well as have more complications or poor outcomes from surgery. And I think a lot of this stems from, like Dr. Tedrati mentioned, sort of trying to understand what access people have to various surgeons and various care for their fibroids. And so, of course, this conference is not just about talking about disparities, right? We want to understand, like, how can we actually address these disparities and what can we do? Because, we can talk ad nauseum about the existence of these disparities. And so, we know that equity is not equality. And so if something affects one group at an outside impact, then we want to think about tailored or targeted approaches to try to actually address that. And when you think about health equity, you want to, allow for opportunity, remediable differences. And I think one part that was very important to me and our team was to reconsider previously taken for granted beliefs about health and healthcare. And so previously we, in our institution, our model was that a patient, kind of came in, they knew they had fibroids, they didn't know which surgeon to go to, they didn't know what to do as far as care for their fibroids. And so what we try to understand is, well, how can is this an issue in our institution? And how can we move forward to affect some change? And self-reflection is definitely the first step. Like we said, self-reflection and data and history is going to tell us how we can move forward. And we did this through these various efforts, starting with the health equity work group, which I'll talk about in just a second. There was a Penn Health Equity Work Group that was started in 2019 with the exact effort to try to address the disparities that we saw that were existing within our institution. And that focused on education and quality improvement. And we wanted to create measurable outcomes, metrics, and dashboards to actually assess these disparities and monitor the progress. And in order to figure out how to do that, we drew from some of existing data in public health on the Health Disparities Index. And so this Health Disparities Index was actually born out of attempts to allow states to kind of understand what are the health disparities that exist to inform legislative efforts. And this data, basically what they looked at are the six most kind of glaring disparities nationwide in the United States, and looked at cancer, cardiovascular disease, diabetes, HIV, AIDS, infant mortality. And what they did is they looked at it as a binary, yes or no, mortality from one of these conditions. And as you can see on the top here, so a health disparity index less than 1 indicates less of a disparity, so no disparity. A health disparity index greater than 1 was more consistent with this disparity. And so the top A indicates Massachusetts, and the bottom is Illinois. And one thing they found is in this study was that states that had a higher percentage of Black patients had tended to have a higher disparity index. And I highlighted Pennsylvania, where I currently practice, and we were in that higher disparity index group. And so what we did when we said, let's calculate our own health disparity index. Let's try to understand in our institution what's happening in gynecologic surgery, what's happening with our fibroid patients. Are we doing a good job? Do we have a disparity? And so we chose various reportable events, and this can be done. We did it in obstetrics, we do it in gynecology. It can be done really in kind of any area. And they have to be a binary yes or no of these reportable events. And we collected the frequency of these reportable events by race and calculated the Black-white disparity index. And we report this on a quarterly basis in our quality forums in patient care. And one thing we found was that we noticed that we were having increased disparity index on morbidity of surgery for fibroids. And we tried to look into why was that happening and what could we do. And one of the papers we published looked at sort of increasing the number and access to high volume surgeons within our institution. We looked at a pre and post intervention group, 2020 being the time where we started using this health disparity index, as well as the time when we increased the number of minimally invasive gynecologic surgeons in our department. And we saw that, in the pre and post intervention group, we saw an increase in minimally invasive hysterectomies for all patients. Overall, it increased 63% to 82%. And then that was most pronounced effect in our Black patients with a 22% increase in minimally invasive hysterectomy. And so when we looked at the post-intervention group, there was actually no difference by race. So through this targeted intervention, we were actually able to show that, like we said before, the intent was to try to decrease the disparity, which we did, but in the same time, we increased overall minimally invasive hysterectomy rates for all patients. And we also looked at this through reducing morbidity in fibroid surgery itself. We talked about anemia in pregnancy. Anemia in general, increases risks of perioperative complications. And we looked at over the course of a year, our anemia rates in our patients. And we saw that there was for each unit increase in preoperative hemoglobin, it reduced the odds of postoperative blood transfusion by 56%. And we know that surgical morbidity can be associated with blood transfusion. The other thing we realized, and sort of depicted here, we realized that these rates also varied across practice sites. So our original model was that we had various practice sites, a resident clinic, other faculty clinics, and they were staffed by various surgeons with different levels of training and different levels of expertise. And we saw that overall, our Black patients had an overall lower hemoglobin and higher transfusion rate, which you might expect. But we also noticed that there was a difference of how patients were treated across our very own practice sites in our own institution. And so we put all of this information together and we said, how can we improve not only access and as well as equity for our patients? How can we kind of help patients navigate this system? How can we go from a physician-centered approach to taking care of our patients to a patient-centered approach so that patients can be, better navigate our system and lead to improved outcomes? And so that was the impetus for founding the Penn Center for Integrated Fibroid Care. I put together a proposal really under the mission of these kind of 4 pillars: equity, access, innovation, and research. We started with standardized care delivery model. We pulled in all of our relevant stakeholders in our department and in other departments to understand what kind of care do we think is sort of the optimal care for our patients with fibroids. How can we move that forward? And what do we think is going to be the best model to make sure that that's equitable? And as well as to increase access for our patients to specialists who take care of patients with fibroids, particularly when it comes to minimally invasive surgery. And so we formed a multidisciplinary team, and it's myself, a nurse practitioner, a new patient coordinator, and we put together a concerted effort to bring together all of these team members. And we meet on a regular basis. We review cases. We try to understand, what is the best approach for the more complex cases. And we came up with this model. So instead of a patient just kind of showing up to whatever practice they happened to call and have surgery with whomever they happened to, whose office they landed in, we created sort of this pipeline model to try to bring together the patient's information, their records. The patient would then see our nurse practitioner for a standardized intake visit. We would get all of the appropriate imaging, establish the patient's symptoms and treatment goals. We screen for anemia and a lot of education. Every patient gets, videos and the same sort of handout education so that they understand kind of what their treatment options are and what is going to be appropriate for them. And then based on these predetermined guidelines that we put together, we help the patient figure out which surgeon is the appropriate surgeon for their condition based on their situation. And in doing that, our goal was to try to increase, access as well as equity so that patients could have access to all of the various options for treatment for fibroids. And so far, we've seen 211 patients. And as you can see, the majority of our patients are of reproductive age, and actually 62% of our patients are Black. Part of the initiative to start this program, we spoke with community stakeholders as well. And the community felt like patients didn't know where to go if they have fibroids. And so they felt like this was a good place for them to come for second opinions, to try to understand, what are their options for care. And the majority of our patients have received minimally invasive procedures, and we've been able to close the gap on a lot of the disparities that we see in our institution and in our city of giving access to some of the procedures that patients might not have otherwise had access to. And so this was just an example of kind of one way to kind of start from knowing that a disparity exists and take that information and try to boil that down into data that we can actually act upon, and then build a program to try to actually address those disparities. And so, I would end that by saying that, understanding the history of not only our specialty, but as well as, the history of a disease process or the history of why a disparity may exist, definitely allows for more self-reflection and questioning. That diverse experiences, of course, lead to asking different questions and trying to understand an issue from a different perspective. And that focusing on disparities that we can address, we're going to get a lot further than sort of disparities that we don't have as much control over. Excuse me. And then ultimately, equity can be achieved through deliberate action after taking on that data. Thank you, and go Birds.
Excellent. Well done. Excellent. Very much. Thank you. Thank you for that great talk. And I'm just gonna point out what she just showed you was one of the things that Dr. Correa explained in his first slide, was how these curb cutting strategies, when you identify a disparity, you address it. And you're gonna not just help that marginalized community, the entire system actually benefits. And we did the exact same thing. When I became head of neurology at our hospital, immediately I said, let's look at the numbers across the board for our thrombolytics, people getting TPA. We found that a quarter of our patients were Black, Hispanic, Asian, and they made up 0% of the ones getting this really important treatment. And you did a curb cutting strategy like you just illustrated there. And what did we do? We more than doubled. Well, first off, the numbers became equitable. It was about the numbers of people getting the thrombolytic matched the general population, and we more than doubled the people getting the actual treatment. So also white patients went up a lot. So everybody benefited by actually addressing that one disparity. And you did a really beautiful job of illustrating that point. We'll take some, Ms. Bagwell, you have a question?
Yes. My daughter's in your demographic. When you talk about anemia and vitamin D deficiency, is that an outcome of the demographic? Not just because they're Black, but because of the socioeconomics, because of drugs, because of does that play a large part in it too? It's not just about race. That I'm just wondering.
Well, I mean, anemia in and of itself with fibroids cause excessive bleeding, and many times people sort of just deal with that and they don't realize that that can lead to anemia. So in our patient population, that's probably a lot of it. Okay. The vitamin D deficiency aspect, is often related to, it takes 3 to 10 times more sun exposure for someone with dark skin to achieve the same level of vitamin D. So really, supplementation and diet and things like that really are more of it than like a genetic component of Blackness. Okay.
And I saw a bunch of hands go up, so let's try to.
Thank you. My name is Dr. Trugi. I'm an emergency medicine physician at Metropolitan Hospital in the city. I'm not sure how well you are aware with the hospital system in New York.
I trained at NYU, so I'm familiar.
So we suffer from having very little money. I mean, the budget in New York City, where the system is $1 billion in the red every year.
Yeah.
We go to the citizens of New York City for tax dollars to try to support. The problem we have is, and I have a huge problem with access to care in my hospital. So as much as we want to pretend if you have a headache, you can't wait 8 weeks to go to the clinic. You have to go to the ER.
Mhm.
And so I commend you for the work you do, but much of what I saw, and I could be wrong, was financially limiting to me. So having a whole team of resources in my hospital, typically the cuts first happen at our ancillary care. They don't want to cut physicians, they cut ancillary care. And then even the part where you say, you know, we hook them or connect them with the best physician for that specialty. I don't know but in my hospital, it is next man up, next woman up when it comes to procedures. It just seems like you're doing wonderful work. It seems hard to translate to my
Yeah, well, and honestly, it's not meant to be a model that like a different model may work for you, right? So what we did is we looked at like our institution and like what would work for our model. We actually toyed with different types of models. And so, you know, we had a lot of emergency medicine, internal med, we had a lot of stakeholders come together and say, I don't know if that's going to work. Like, you know, so yeah, I agree. It's not a model that necessarily works for everyone. We do have a precedent in our institution for what they call fast track to fertility, for example. So there's models where sort of doing this kind of standardized intake, you know, the thought is that it actually decreases the number of visits, because previously our patients were going to this person and then that person was sending them to another person and then they were ending up at another person. And so we've decreased the number of visits that a patient sort of has to hop around to get to the ultimate surgical procedure that they need. And we've also introduced it relevant to use ED fast track scheduling. So there'll be patients who come to the emergency room who have bleeding and fibroids and anemia, and they get their ultrasound. And then you're like, you got to follow up with GYN. And they're like, we don't have access. So we see those patients within 2 weeks. Like we have a specific pipeline for those patients. So I think you're right. It's not going to work everywhere, but sort of thinking about your individual institution and sort of what are the needs and what are the disparities and sort of targeting
I'm
that.
not saying we can't do things,
Sure,
because
sure,
we
sure,
do some good work in the
Yeah.
hospital. It's just.
No, I hear you. I trained at Bellevue, so I understand they're listen, drawing blood, transporting patients, the whole thing.
Thank you.
Great. All right. I think that's all. Well, I'm
Thank
going to
you.
turn the mic. Thank you once again, Dr. Farrow. Wonderful, wonderful talk. Great illustration. I am going to turn the program over to my good friend and colleague, Mathilde Roman, who will introduce the remaining speakers for the afternoon.
Thank you, Dr. Etienne. So the next presentation is going to be delivered by Dr. Stephanie Rand. Dr. Rand is a program director for Montefiore Einstein Physical Medicine and Rehabilitation Residency and an assistant professor of rehabilitation medicine. Dr. Rand is the director of Montefiore Einstein's prosthetic and orthotic services, practicing general rehabilitation medicine and musculoskeletal medicine, including osteopathic manipulative treatments. At Albert Einstein College of Medicine, she teaches in both the preclinical and clinical years, lecturing students during the musculoskeletal courses and mentoring students in the service learning and impact courses, as well as precepting students and residents in clinic. Clinically, her focus is on general and amputee rehabilitation. I'd like to welcome Dr. Rand.
Thank you. Thank you for having me. Thank you for allowing me to give voice to disability and accessibility in this absolutely amazing day. Our objectives today are to evaluate the environmental barriers and facilitators and how they impact negotiating obstacles. We're going to briefly talk about legislation, ADA standards and compliance, and then I'm hoping that you will be able to analyze efforts to maximize function and diminish handicaps and promote inclusion for persons of all abilities. When I was a medical student, these 3 definitions from the World Health Organization were drilled into anybody applying into physical medicine and rehabilitation. But they've started to lose traction, and now we're no longer a part of the World Health Organization, but they're still extremely important. So the impairment is the physical loss, psychological loss, or anatomic loss of function. This is visual impairment or blindness. This is the stroke that resulted in a left-sided hemiparesis. The disability is the restriction or the lack that resulted from the impairment. the inability to see obstacles in front of you if you have a visual impairment, the difficulty ambulating in tight spaces if you have a hemiparesis. A handicap only exists when society or the built environment puts up barriers that make the impairment or disability prevent the individual from functioning at the same level as the able-bodied. To put mention up of the American with Disabilities Act, has 5 titles, covers everything from communication to work environment to public resources. This is the what we must do. The USA standards is the how we do it. First published in 1975, republished in 2003. This document covers details of everything of how we make our spaces accessible, from doorways to bathrooms, where to put the grab bar, whether you can have the grab bar on one side or the other will matter, whether the person needs to transfer because the left or right side is weak. How high a sink needs to be in order for a wheelchair to get underneath it. What to do if we have a water fountain that doesn't have space underneath it. How far can other obstacles be so that people can still negotiate the items? And even outside spaces, including how steep can a ramp be before it's unsafe for a wheelchair or a rollator. Now, I'm going to talk mostly about urban health because I've spent my entire career in the Bronx at Montefiore Medical Center. So I'm an urban physician. But this idea of urban and rural health is not a new issue. Hippocrates published about it in 400 BCE to help physicians predict what they might come across in different parts of the empire. There was a significant uptick in interest in the 1600s as we industrialized and saw significant differences in the healthiness of people who were living in the country versus living in the city. From the 1999 to 2020 census, we have not seen a big demographic shift of where our population are living. We still have about 80% of the US living in either urban or urban clusters. That includes suburban areas, and only 20% living in rural. Did the color just change? Okay. People in the more rural and the inner city are both equally likely to live in poverty, experience higher mortality rates, and have poorer health statuses than the suburban individuals. But it's not all bad news. The US Department of Agriculture has showed that urban residents have lower rates of age-adjusted mortality, disability, and chronic disease compared with far rural. No statistically significant differences in disparities, but more accessibility to healthcare resources, because our accessibility declines the further as population density declines. So we see rural patients typically going to generalists instead of specialists. We know that urban settings has more hospital beds, physicians, nurses, and specialists per capita, and that rural residents have a travel burden associated with access to their care. But we know that different parts of the urban environment have different barriers at the physical level for the people who live there. A study by Clark et al. Out of the Chicago inner city area showed that over 60% of residential blocks had at least one street in fair or very poor condition. For people living there with mild or no physical impairment, street quality had no statistically significant effect on severe mobility disability. But as the streets fell into disrepair, the people who lived there had a harder time getting out. So this not only caused a difficulty in access and a difficulty in making it to their appointments, it often also forced people to stay inside in buildings that were run down, that had higher rates of mold, less air conditioners, higher risk factors for respiratory disease. So we saw an impact on health, both because of an inability to get places easily and difficult living situations. We know this is true from throughout the country. Alameda County is in the Oakland area of California, showed an association of poor neighborhood environments with a double the risk loss of physical function in aging populations. And in St. Louis, again, people who lived with adverse neighborhood conditions were more likely to report trouble getting around. Here in our most close city, big city, New York City, the team studied all 5 boroughs, looking at 134 people. About a little over half had visual impairments, requiring either a guide dog or a long cane to negotiate the built environment. And the other, not quite half, were manual or motorized wheelchair users. And the people were surveyed and came up with all the different ways in which their environment is affecting their ability to participate. But what did we find? That there were many barriers: inadequate maintenance of basic facilities and accommodations, as well as lingering negative public attitudes about what it meant to be ambulating with a walker. I hear this all the time from my patients in the Bronx, that I don't want to be seen as weak, so I don't want to use a cane. I don't want to use a walker. It'll make me vulnerable. I'm so glad that we already discussed what a curb cut was. I wasn't really sure if we were going to have that one. I'm so grateful. Curb cuts, smooth payments, and barrier-free sidewalks promote mobility. But people found ways to overcome this. They often had to plan their outings and plan more times, planning routes that included accessible subways or accessible buses, or easier to get into bodegas, easier to get into libraries, easier to get into hospital buildings, where many of our hospitals have one entrance that's upstairs and one entrance that's where the ramp is around the corner versus straight entrance from street level. This is my borough. This is the Bronx, and it's a busy street. It's a lot of busy streets. It's a lot of noise. It's a lot of people. It can be hard to get through if you're able-bodied, but if your mobility is impaired, it can be 20, 30 minutes added to your commute attempt to get to your appointment. So how do we cross the street in New York City? As of March 2022, which was the most recent data published by Department of Transportation, there were over 13,000 traffic intersections with traffic signals throughout the 5 boroughs. Traffic signals will time from 45 to 120 seconds. And the timing of each signal is determined based on traffic volume, traffic patterns. This is the traffic signal, right? So when the hand is steady, it is saying do not leave the curb. When the person is walking, that is indicating to you that it is safe to leave the curb to start crossing the street. And this is a 7-second minimum, except in places where they've determined there's some low traffic volume, in which case it could be 4 seconds. The flashing hand or the countdown is letting you know that you can still be in the street, but don't leave the curb now. We don't think there's enough time for you to get across the street safely anymore. And then there's a 3-second buffer, which is probably one of my favorite things I learned, and after, going through this 800-page manual, because I like to use it to decide whether I can, still turn quickly or not, but that's not really what it was there for. The pedestrian clearance time needs to be sufficient to allow a person to cross the street traveling at a walking speed of 3.5 feet per second, which I will explain why briefly later, to get all the way across. But is that fast enough for everybody, right? So after a stroke, we have two studies that have looked at different ways of testing walking speed, one using a 10-meter walk test, which found an average walking speed of 2.4 to 2.7 meters per second, which is about 8 to 9 feet per second. But another study showed that this is really an overestimate, because if you pull out the distance they need to walk over 6 minutes, we find that we're overestimating by maybe even 50% the distance, the speed predicted for individuals with similar physical characteristics. But we'll still use it. We'll still use data. We'll do some math. So we know that we have 45 to 120 seconds to cross the street. Normal average walking speed is considered to be 3.5 feet per second. It's also the average speed of a power wheelchair. They can go up to about 9 feet per second, but rarely, none of them go less than 2 feet per second, and they can all easily make it to 3.5. Manual wheelchairs and post-stroke walking is about 1.7 feet per second. Our average streets in New York City are 22 feet across. Fifth Avenue is 50 feet across. The change interval only has to get you to the median in the middle. So that's why I use Fifth Avenue, because it's one of the widest streets that doesn't have a barrier in the middle that you could stand on. We take out the 7 seconds of the free to walk sign from the 45-second cycle, gives us a 38-second pedestrian change interval. If you have to travel that, if you have to travel 22 feet in 38 seconds, you would be going 1.7 feet per second exactly. So the Department of Transportation did in fact read a study before they picked this minimum. If we go with the widest that's in the city before there is a median, a barrier, 50 feet at 1.7 feet per second gets you 85 seconds. So you're still well within the 120-second maximum, which is good news for New York City. This is one of my favorite cities in the country. This is Savannah, Georgia. And I use this picture because if you follow the crosswalk, you will see that there is no curb cut. It is a beautiful city, but this does still exist in our country of areas without accessibility. And this is a really main street in Savannah, right across from the big cemetery that everyone goes to. Beautiful, but not accessible. How would somebody in a wheelchair get over a curb if there's no curb cut? And the answer is they have to pop a wheelie. Learning to use a wheelie for a wheelchair user is an incredibly important skill. Not only for this incredibly cool gentleman who is going down an incline and he's going backwards so that he won't roll quickly because the incline is too fast otherwise. Also to get the casters or footrests from bopping into something. Casters are those little wheels on the front. The big wheels in the back are under axle control, under push rim control. They're directed. Any wheel on any device that is not under axle control is called a caster. So those little wheels on the front of the wheelchair, those are called the casters. So they'll drop into potholes, they'll drop into soft ground, they'll drop into gravel. Both the casters and the footrests have to go up to hit the curbs. But are we teaching this to our patients? No, only 4% of wheelchair users can actually perform even a stationary wheelie, let alone one while propelling themselves forward. Why? I'm sure it's multifactorial. A lot of the time we don't teach it. We're afraid to teach our patients how to do this because we're afraid they're going to fall backwards, but that's not okay. This is how they need to traverse the environment. Sometimes the wheelchair user themselves is afraid to learn. Sometimes the wheelchair itself is not conducive to it, depending on how we raise or lower the axle. We alter their center of gravity, depending on how we shift the chair forward or backwards. Over the wheels, we'll make it more likely to tip backwards or less. We tend to pull it so that they're less likely to tip backwards because we don't want them to fall backwards. But that's great at the beginning of someone learning to be a wheelchair user, but that is not effective later. So we need to then alter their wheelchair. And sometimes the environment, there may not be opportunities for somebody admitted to rehab to train to use a wheelie and pop over obstacles. And yes, you can do this in a power wheelchair too. Depends on how the whether it's a mid-wheel drive or a rear wheel drive and how you do it. But yes, everybody, any wheelchair user can learn to use a wheelie. Other pressors, other environmental barriers. Even if you're not, if you've never used a wheelchair, if you've ever run, you know that there's a lot of slope built into streets, into sidewalks for drainage. Sidewalks typically slope towards the street for water drainage. Manual wheelchair users need to push the downhill wheel harder than the uphill wheel so that they don't go veering into the street. Power wheelchair users need to pull the joystick to the opposite slide slightly so that they're not going veering into the street. Cracks and damage to the streets and sidewalk will make it difficult for wheelchairs to go over them. You need to accelerate to get over them and need to be able to pop the wheels back so that you cannot. So where do we go from here? Things that we're doing, I have a group at Einstein of students who are doing an accessibility survey of the medical school. This was one of the courses that I teach in. It's called the Impact course, where they are given time for scholarly activity. So they are going and we are looking at our lecture halls, at our labs, at our housing facilities, and looking to see that we can make the medical school accessible for both physical, visual, and hearing impaired students. I encourage you to do the same. I thank you for allowing me to include disability, ableism in the DEI discussion. Being an ally in this battle helps because I really feel like we're hitting the same concepts home. Cutting the curb helps everybody. And I encourage you to try an accessibility survey too.
Hi, Dr. Rand. I was wondering, who do you think I guess, who does most of the responsibility fall on for this issue? You brought up many different things, but as far as like accessibility and, you mentioned issues with streets and like, there's so many different people that could be responsible, but who would you say, just based on your expertise, like is mostly to blame or at fault, or who's most responsible for these things, and how what does change actually look like, as opposed to the which I think is wonderful, like you're presenting the importance of adapting to the reality of things, but is there an alternative?
Anybody can be an ally. I think everybody should take some role. There's data that I didn't present that looks at New York City subway systems and how in like 2010, something like 10% of the subways were accessible, and now we're up to about 30%. And there's a goal to make all of them. And even that, depending on how you look at the data, it looks a little because they've really only made Manhattan more accessible. But then if you look at the data, that is where all the travel is going in the subways. So I don't know, you could go back and forth and fight it. I think that there's a lot of ties between legislation and funding for activities to make the environment, the built environment, more accessible. I don't know where that's going to go. It's not something that we usually think of as privatized. We think of that as government funding. And I hope it remains there. So a lot of the times, studies like these done by interested clinicians or interested psychosocial allied health professionals are used to then advocate during days on Capitol Hill, days up in Albany, et cetera, to show proof, because it's very good to say these are the things that will work, but often we know without proof we can't get funding, whether it be from government or private sources. So I think it's a area where we all have to work together, and there is a role for the clinician, and there is a role for the individual, and there is definitely a role for legislative support as well.
Thank you.
And I'm just wondering, can you speak more, more broadly about, that disconnect between like the regulations that exist, right? Because we have many regulations within our complex healthcare environment that mandates us that whether it's, disability and making sure that we have accessibility, talking about even things like language access, and yet there's still this kind of gap. And can you elaborate a bit about like the existence of that gap and how, as being an ally, but like where does advocacy fit in?
A lot of the built environment of our big cities predates the American with Disabilities Act, which is only the 1970s. So we do have more strict codes applied to newer buildings than older buildings. Think of the New York City Public Library and how big and beautiful it is as a building. But I think it's got to be from the 1800s. It did not conceive of accessibility, because the way we thought of impairments and disability was very different back then. There was no light on including people with impairments really before like the 1920s. We start to see my whole field of medicine and all of the major changes in legislation, starting with the Smith-Fees Act, and when World War I soldiers were coming home having significant injuries, and this was our young male workforce, and they were supposed to be the people that provided for our entire country, but they were suddenly coming back losing limbs, and it became a realization that we couldn't not include them. And so that's what really the impetus to even cause any of the start. So we're still in the infancy of it. It's 100 years of our history that we've even been including people of all abilities into the structure of society. So, you know, just like we've talked about thinking about the atrocities of early medical research on the Black population, we have to understand that some of these buildings were just built before we could even conceive of being inclusive. Thank you. Thank you for having me.
And so now I'd like to bring up Dr. Courtney Brown to present. Dr. Brown is a physician and faculty member at New York Medical College, where she served as a diversity and inclusion officer and assistant course director for the multiculturalism and medicine program. Dr. Brown focuses on improving diversity in medical education and addressing healthcare disparities. And her clinical interests and academic interests are in chronic pelvic pain and disability advocacy. Dr. Brown is passionate about her interdisciplinary care and advancing equitable healthcare solutions for underserved populations. And so I welcome Dr. Brown.
Hello, my name is Dr. Courtney Brown. I'm fighting a cold right now, so once my voice goes, this will be done. I'm going to be talking about the importance of pathway programs to medicine. I have no disclosures. So this is going to be a mostly foundational talk about pathway programs, also called pipeline programs. We're going to define pathway programs, explain the importance of explain their importance, and then highlight their impact. And I'll end with talking about what we can do in the future to make sure they're maintained. So as we know, the road to any STEM field is very complex, especially if you don't have exposure to the STEM fields. And so what is a pathway program? Pathway program is a structured initiative to find qualified applicants interested in STEM fields. And it can range from elementary school all the way through residency. And then the benefit of these programs is it takes individuals who may not have access to the academic or clinical experiences that would lead them into STEM and offers them academic preparation, mentorship, clinical exposure, and research opportunities. So like I said, pathway programs or grade to medical school programs can range from elementary school all the way to being an attending. I like this picture because it's a pipeline and you can enter the pipeline at any point. And the goal is that we support these students as they move through the process and determine where they may want to fit within STEM. And that's important because if you ask a student, what are you interested in? They may not know. They may not know what's available. They may not know they can be a nurse or like what it is to do basic science research. What it is, maybe they want to be maybe they thought they wanted to do medicine. I had someone when I was in high school was the head of all the medical clubs, saw blood for the first time, passed out, decided that wasn't for them. But you don't know unless you're exposed. So here are some examples of pathway programs. At NYMC, we have the Black Men in White Coats it really ranges from elementary school children to all the way to high schoolers. There's also the Med Academy, which is a summer program for high school students in their 3rd or 4th year. The amazing thing about this program, it's a 4-week summer program that really helps individuals determine what they want to do within STEM. And as they're moving through the process, once they finish the program, they can actually get 5 credits of college credits from that university. Then we also have the White Plains Youth Borough, which was something more local that was done at NYMC. For undergrad, there's a Summer Health Professionals program, and that's a program that occurs in your 1st through 3rd year actually know individuals who went through this program when I was an undergrad, and one is now a dentist, another one is a pediatrician. And so this program really helped them to find mentors, to find clinical experiences, and just solidify the fact that they wanted to go into medicine. And this is a program that's at 11 different institutions across the United States. And then there's also programs that occur between undergrad and medical school. Here we have the pre-health enrichment program. Some of the students are back there. That helps support students as they apply to medical school. And at New York Medical College, there's the AMSNI program, which is the Association of Medical Schools of New York, Associated Medical Schools of New York, which helps support students as they traverse the field to get into medical school, make sure they have a strong academics before they enter medical school. And then for medical school and beyond, there's the pre-matriculation program, which is something we do here to support first-year medical students before they enter medical school. There's combined medical school residency program. So I know someone who did a combined internal medicine cardiac program, and that really helped him get through residency. This is just a picture of the Black Men in White Coats initiative. There's over 500 students this past year, and it really helped expose students to different aspects of STEM. It also gives you an opportunity to contact people who are already in medicine or other STEM fields, exchange information, get mentors early. There's also the White Plains Youth Borough, which I talked about before. And this is just an opportunity for high school students to gain larger exposure to STEM fields. But why does this all matter? Why do we need all these programs to help bring people through the system to potentially be a part of STEM fields? So I talked more locally, but I want to stay broad. I want to go more broader. So for the AMC, they did an analysis of the current active providers or physicians, and they saw that although women are 50% of the population, there's only 38% of active medical providers. So right there, that's a large discrepancy. Then on top of that, for female physicians, 66% tend to go into pediatrics, and then 63% do go into hospice. So that's also an issue. That's also an indication of why don't potentially male providers want to go into pediatrics, right? So you see there's a discrepancy. And then in terms of percentages, a lot less female physicians go into sports medicine. It's only 7.7% of active physicians are in sports medicine. So by potentially getting these students exposed to sports medicine or whatever, or pediatrics early enough, you may get them the mentors and the clinical experience. They say early, hey, I want to investigate these specialties, and hopefully you'll change the physician force in the future. Another issue is racial representation. So even though the Hispanic population in the United States is 19.5%, only 6.5% of our active physician force are Hispanic or Latino. Same thing with Black or African American, only 5.2% are identified as Black or African American, but we make up 3.7% of the population in the United States. And then for American Indians, they make up 1.3%, but in the active physician population is only 1.1%. And then for Native American, it's actually very so close. Even though a statistic may be close to what's found in the US population, what you don't want is for that number to start dropping. So these programs also help sustain the numbers we currently have. And then something that a lot of people don't think about is location. So in Idaho and the American Samoa had the lowest number of active physicians in the country. So by finding students who are interested in maybe going back to, or either from Idaho or going to Idaho, you can help support patients in rural areas. So what's the effect of pathway programs? What's the effect of identifying these numbers and helping to ensure that we expose students to different STEM fields or medicine? Well, overall, the emphasis I want to say is that all these applicants are qualified. I think sometimes, especially with heard statements are being made, you think that it's just you're taking students that aren't qualified and elevating them, but the GPA of students who were a part of these programs, the GPA actually increased for high school students that were accepted for undergrad students who are accepted into medical school. So their average GPA is 3.84 as of the class that entered in 2024. Also, some programs have a 65% participation go on to successfully join a health field, which is really amazing statistic, showing that the support is working. And then they're also more likely to graduate from medical school and pursue residency. So it's not just getting into medical school, but it sustains them throughout. Additionally, there's 11% in military veterans. There was a wider age range from 18 to 62. So the average medical school age is around 25. So the fact that we are getting older students with more potentially life experience is a great thing for potentially when they're in a patient room and the patient is starting to talk to them about PTO and like disability, they'll understand it a different way. And then the class had a greater commitment to community service. And then as I spoke about gender before, so even though their active population of female physicians is 3.8%, of the class of 2024, the class coming in 2024, the enrollment was 54.6%. So it's showing that there is an increase and improvement in the pipeline coming through for the active patient population. And the same thing about sustaining. So with men, for 6 straight years, there was a drop in the amount of males entering medicine. So now there's an improvement that was a 1% increase. So this is improvement. This is important, but not just increasing, but sustaining. And the same thing with race. So there was a 14% increase with American Indian. There was a 4.5% increase in Hispanic population, and then there was a slight decrease in the African American population, but at least it didn't the bottom didn't fall out of the group of students going into medical school. And then one last thing is the economic changes, which I think is very important. So there was an increase in economic diversity in medical school. Most people who go into medical school, given that medical school is so expensive, are middle to higher income. So now by having these pipeline programs, it showed that matriculants parents actually, their highest level of education was, there was an increase in the amount of matriculants whose parents' highest level of education was lower than a bachelor's degree. So you're getting more economic diversity, more experience with different things. And overall, what we want is for hopefully the physician workforce to resemble the greater population that we serve. So people have a greater connection with their physicians. And this is just more local. So I know I'm being more global, but I think it's important to include the local impact you can have on your own. So with the White Plains Youth Bureau, New York Medical College, they were able to show 100% of students said they learned a new career path. And then 100% of students said they were motivated to work harder. So this isn't just affecting STEM, this is potentially affecting a greater variety of fields. Similar to what Dr. Etienne said before, when they started cutting the roads to help with accessibility, it was for one group, but really it helped a larger group of people because a rising tide lifts all boats. And just say, so overall, why is it important to do these programs? You can it's important to do these programs because a diverse healthcare team leads to better patient outcomes and increased patient trust. It's been shown that physician-patient racial concordance and disparities in help with disparities in birthing mortality. So when there was physician-patient concordance, it showed in one study that there was a decrease in Black fetal mortality. So what can you do? So you can start by supporting current programs. If you're interested in STEM or even really in any field, you can say, maybe I'll start mentoring people. If you're a student, you can be a mentor. If you're out in your field, anyone can truly be a mentor if you want to. You're willing to take the time and dedicate yourself. Or if you can't be a mentor, you can be a sponsor. You can start saying the student's name in rooms they're not in. So you maybe don't do the day-to-day, but you make sure that they get opportunities. And then lastly, these programs can be considered by admission. So if they showed longitudinal interest in the field, then by joining these programs early, that's important for admissions committee to consider. And then just make sure you engage with your community to ensure that you partner with them in bring these programs to life if there's none that's existing already. Yeah, so overall, they bridge gap in access, they improve diversity, improve healthcare outcomes, and the investment in these programs is an investment in the future. That's all I have.
Do any of the participants in the pathway programs ever come back to share their stories and the benefits of participating to maybe encourage current participants to stick to it and, pay it forward?
One of the cool stories at this year's Black Men in White Coats, one of the student volunteers was actually a medical student at Mount Sinai. So he came back to the Black Men in White Coats and was basically sharing a story, also mentoring. But that's actually obviously very, very important. Yeah.
I almost did that once, but I got my wisdom teeth out the same time as graduation. So yeah.
I just wanted to follow up on your question. I'm actually a student that matriculated into NYMC through the AMSNY program. So we do things like going up to Albany to speak to college students as well as legislators to advocate for more funding for students like us.
So want to invite our last panel speaker, last but not least, Rahim Hirani is a fourth-year MD PhD student at New York Medical College. He is deeply involved in leadership and advocacy, serving as the president of the Graduate Student Association and the executive director of the New York Medical College Center for Human Rights, where he oversees a student-run clinic that provides forensic and psychiatric medical evaluations for asylum seekers and victims of human trafficking in New York. By the way, I used to be an immigration lawyer back someday. So dear to my heart. Additionally, Rahim is a project coordinator at the Office of Diversity and Inclusion at the New York Medical College. So take it away.
Thank you so much for the introduction. So, just piggybacking on the last talk, that what we can do in the pathway programs or medical students, this is an example of it, right? So the topic that I will be talking about is transforming medical education, addressing systemic racism and implicit bias through NYMC's TELP initiative. Now, TELP stands for Transformative Education Leadership Program, which was born here at NYMC, and I will be talking about that, what TELP cohorts or students did with this program. So what is TELP, right? It's a longitudinal educational leadership program, which was basically born out of a AOA grant. Now, AOA is a honor society in medical school. If anybody is not aware of that, they have a service leadership grant, and this was a grant which was spearheaded by faculty and students. Two of the students that you will be seeing in the next slide that I will be talking about, the team that started this program, They put together a grant, submitted, and they successfully received this grant. And through that grant, they developed this longitudinal educational program, which became a part of curriculum. So this is the team, as we call it, the OG TELP team. So as you can see, the two students in the first two pictures were M2s at NYMC when they tried to write this grant and successfully gotten it. So Dr. Lior Levy and Dr. Radab Al-Nifedi, so shout out to them. They are residents currently. Dr. William Frischman, Dr. Pamela Ludmer, and Dr. Militian supported this grant, and they have been the pillar of, making sure that the program is still running. So I want to describe the program layout really quickly. So what happens that rising M2 students, typically 7 to 8 students, are selected through each class every year since it started in 2021. And I was one of those students in 2020, the second cohort, so 2022, 2023 year. And with me, there were 7 to 8 students which were selected for this program. And when we are selected in the following summer, we go through an intense online course with Dr. Etienne and Dr. Ludmer on leadership and skills needed to address bias and racism in medicine. Because if that's what we want to target, we need to be, learning about how to do that. So I thought it was a really good course in terms of, explaining what are the different types of leadership, what are the different type of biases in medicine, how we need to be, aware of our implicit biases and how to tackle them. So once we do that, the students collaborate in the group on their class cohort, and they develop a project that they work on throughout the year with the mentors, Dr. Etienne and Dr. Ludmer. And of course, shout out to clinical skills team because they're a huge part of it. We develop a standardized patient encounter with all their help, which becomes a part of the curriculum. Before students go to clerkship, that same M2 class that students were picked from, those students go under a standardized patient encounter of intervention, sort of, that I will be talking about in the later slides, that how to best navigate those conversations with patients, with healthcare providers, and in life in general. So this was the framework that we use, as we call it, vitals, to interrupt microaggression, which, it stands for something that I will be talking about in the next slides. But this was a paper which basically, presented the framework of this term. So vitals, V stands for validate. So for example, once you hear some comment that you think is a microaggression, the best thing to do is first validate your feelings and experiences, how you are feeling. Are you angry? Are you frustrated? Are you disgusted? And if it feels like a microaggression, it is a microaggression. So I in vitals is inquire. Then after you inquire to obtain more information or clarification, right? For example, could you say more about what you mean by that, right? I don't get it. Could you please explain more? Or why is that funny? T in vital stands for take time to mirror and reflect what the person is trying to say. And then emotion behind the statement, because in a lot of the times the tone matters, how it is said, right? And how we comprehend. It could be different, what we understood, what they implied, but it is important to mirror back and take time and think about it. A in vitals stands for assume. So assume the best of each other and need for clarity. So give them a benefit of the doubt, but also validate your feelings and try to get the clarity that you need. So for example, I know you may not realize it, but when you said XYZ, it made me feel XYZ. What are your thoughts? Just one example. And L in vital stands for leave opportunities for follow-up, right? So for example, maybe we can talk about it, at a certain time after we reflect on this. And S for speak up for others affected by negative biases or microaggressions. So for example, intervening or interjecting in someone's, like if somebody made a comment saying that's problematic because it's reinforcing XYZ. So this is kind of the framework that we adapted into our cohort and what we wanted to design as a project, and also the subsequent cohort after what the initial cohort did. So the intervention was basically aimed to address the critical need for students to practice these scenarios in a safe setting. So what's better to do it if not in a simulated environment? And we have a clinical simulation center here. They were great help. So the student cohort basically designed scenarios that we may encounter in those healthcare situations or outside the healthcare environment. And we want to be able to learn and respond to navigate how to challenge those assumptions and also how to have that conversation in a respectable, safe manner. So these were sort of, cases, as you can see, case number 1 and case number 2. So first case, for example, was about the language barrier. So students were given a case that if the patient is frustrated with the medical assistant's accent and they are asking for, can I have a doctor from the US, So case number 2, for example, perceiving pain. The physician does not take patient's pain seriously because of their race or ethnicity, and they just assume that they are here trying to get some pain medications. So these are some of the cases that were designed with standardized patients, keeping in mind the vital scenario. So even standardized patients went through this little training to understand what this vital framework is. And what basically happened that when students came to the clinical simulation center, they first took a pre-survey before they went under this small vitals training, that questions like how likely are you to intervene in these situations if you hear these comments from somebody in healthcare setting, right? And then they went under they watched this short video of vital framework, that how it works and how you can have these conversations. Then they went under these cases with standardized patients. There were 2 cases, so they went under twice. They had a debrief session with the SP, with the standardized patient, and with the student leader. And then they took a post-survey that after going through this experience, how likely do you feel or how likely are you to intervene in those scenarios now? So after this implementation, for example, this is just example of one cohort that 195 rising M3s went under this experience. 51.9% felt comfortable using the skills taught to tackle a microaggression, just like almost half of the people. But most students agreed to broach difficult conversation with peers and those in power to counteract microaggression, which from pre-survey of 34.8% went to 55 something percent. So which was a very significant jump. So just to give these numbers, just to provide an idea that this is one of the ways that we can have an intervention in a school setting, in a safe environment where we can learn to have learn these skills, to have these conversations, which will very well be applied in clinical setting as well. So just to conclude this HELP workshop effectively provided students with some tools and practice in a safe environment, which was needed to interrupt microaggression. And it also gave them a one-to-one feedback to further enhance the session and allowing them to realize what did they do good in those sessions and what could be using some improvements in the future. I want to give a shout out to all the people who were involved in this project. Of course, the AOA grant, the creator of this program, Dr. Leo Levy and Radab, and also Dr. William Frischman, Dr. Ledmer, and Dr. Etienne for their guidance and mentorship for this program, the Clinical Skills and Simulation Center, UCLA School of Medicine, because I stole some of those slides from them. And of course, TELP scholars, I use some of the slides which they presented in national and international conferences. Well, thank you so much.
Great. We'll do a quick wrap. All right, I think we have time for maybe one question. What I usually say when I meet with the medical student applicants in the morning, if we're over on time, I say we have time for one question, but I won't be providing any answers because there's no time. Time is up. Okay, no questions for him? Okay, great. Thank you so much, Raheem. Really nice work. We appreciate it. So we're gonna wrap up. Sorry, we went a little bit over, but we really wanted to have time for really good discussion about these various topics. I do want to thank Wianda Jean in the back, who was extremely instrumental in making sure all logistics are taken care of. Thanks to all the staff in our D&I office, both at NYMC and WMC, who play a major role in making sure that this all comes through effectively. This year, we really stressed when Matilda and I and our teams met, we really wanted to stress the importance of solutions. And, yes, we know all these disparities are out there. There's a lot of bad things going on, but let's focus on what can we do about it. And we wanted to highlight what people are actually doing about it and showing that these interventions really do work. And although we're talking about disparities, we're talking about really helping all of society, because we all really do benefit when we come together and address these disparities. But thanks again for all of you, especially for staying, staying till the very end. We appreciate you, and see you next year at this conference. Thank you.